Good morning to all. My name is Ainhoa Mendizabal, and I work for Grifols, and I'm honored to be the person who welcomes you to our second day. I hope you had a good evening after what was a full day one agenda, and I can promise day two is going to be also as packed with vital topics to the plasma industry. Today's session will focus largely on patient access, a topic I'm passionate about because in my role, I constantly speak to patients, and there's some of them that I know personally. They all say the same thing. How is it, they ask, that with all what is known today about our diseases and the value of plasma-derived medicines bringing to their treatments, there are still so significant roadblocks to access the therapies? In the industry, we talk about the patient journey. Implicit to the journey should be that it should conclude in a reasonable amount of time. For many patients, we've heard, this journey can seem endless and be very frustrating. Professor Van already told us yesterday that many patients can need 4 to 8 years from the first day they start experiencing symptoms of their associated with their rare disease until they have a concluding diagnosis and learn how plasma-derived medicines can be their only or their optimal therapy. And optimal therapies is something we are going to talk today. Fearful, patients become resigned to the fact that they are going to need perhaps plasma-derived medicines for their whole life. And what happens next is something we need to take care about. They also experience challenges when accessing to their therapies. Yesterday, we talked about one of the main challenges. This is product availability. But another access challenge is reimbursement. In Europe, there's no consistency on reimbursement policies. It can depend on which country you are in or which disease we're talking about. Countries known with extensive healthcare reimbursement policies, such as Finland and Denmark, reimburse fewer plasma-derived medicines as other countries that are less wealthy, like Greece and the Czech Republic. And then, in the case there is a reimbursement policy in place, patients often find other roadblocks, like they don't meet eligibility criteria, and they have to pay high cost out of their own pocket. This is stress and anguish for them. Complicating the economic debate is also the fact that there is cost containment measures, and more specifically, what is a cost-efficient medicine. Established and proven therapies, such as plasma-derived medicines, are losing out to new therapies that are high cost. What happens is that payers, sometimes they contemplate new treatments, and they have to consider the overall impact on the country's healthcare system. They need to look to offset this higher cost, and this impacts the existing plasma-derived medicines, as do the additional economic stresses, including external reference pricing procedures and other measures such as clawbacks, payback taxes, and mandatory discounts. They threaten the industry already fragile balance and have an impact on patient access. There has to be a way how to manage the economics that take into account the plasma-derived medicine's unique nature and their clear and undisputable value to the society, given that they have an ability to improve the quality of life of the patients. After reimbursement and cost containment, there's a third challenge, which is linked to the procurement practices based on price only. It is clearly the case that plasma-derived medicines are too often mistakenly considered a commodity. This one-size-fits-all approach is seen in how some European countries are conducting their procurement practices. The tenders look to have the cheapest alternative so that they can purchase or ensure the greater number of units to be purchased and have broader patient population have access to the therapies. This may work for treatments that are considered interchangeable or bioequivalent, such as generics and biosimilars. We know that all plasma medicines are not alike. Switching from one product to another can lead to tolerability and compliance issues, as well as adverse effects. And ironically, this could lead to more cost, which is treating those adverse effects. So there's also an issue of administration. We heard yesterday from a patient. Its route of administration is effective in treating various conditions, and none is better than the other one. But brand, product selection, and administration, route of administration should be a function of patient tolerability and not the choice of a central purchasing figure who, in all likelihood, doesn't have the sophisticated understanding of the uniqueness of plasma-derived medicines and needs to focus on the numbers. Economic considerations should not have this power of decision-making to impact the patient access and the quality of life. In recognition of the proven value of plasma-derived medicines, their nature, and the unique risk to their availability, policymakers should work on optimizing risk reimbursement policies, revising cost containment measures, and aligning procurement policies to the clinical need. However, in the absence of a more informed approach to enhancing patient access, the conversation lately, regrettably, turns on how to ration or restrict access to these therapies. The pandemic-induced disruption in plasma collection has stressed plasma supplies across the continent and led to constraints on treatment. For example, several countries have applied or considered applying forms of patient tiers or levels to decide which specific patient subpopulation should be the first in line to receive the limited amount of immunoglobulins. This categorization of patients provokes controversy about selection criteria and distresses patients and their families, who more likely than not have already turbulences in their journey and don't need another point of anguish because they might be excluded from their treatment regimes. Therapeutic rationing is bad policy, we believe, and should be the only last resort when all else has failed. We shouldn't have to have this ethical debate. While plasma levels are recovering and perhaps further hard choices about who gets treated can be avoided, there already has been an impact. What has happened should be used as an opportunity to avoid the problem in the future. What we should be doing together is working across all interested stakeholders, policymakers, industry stakeholders, payers, to ensure patients have access to the optimal care they need. This is the conversation reset we need, optimal care for our patients. This is what the first session is going to begin addressing today, and I'm looking forward to what I expect is going to be a fascinating and much needed discussion to make sure that the patient journey is a better experience to all. Thank you.
Dear ladies and gentlemen, greetings from the European Parliament in Brussels. Thank you so much for the opportunity to address you with a short message on this important topic, even though I unfortunately cannot be physically present in Berlin. With all your distinguished guests and speakers, I'm sure you're having good debates about this topic. While I am a politician, I'm also a medical doctor, I'm a surgeon. So every week for half a day, I'm working in my local hospital. And this experience helps me a lot in my day-to-day work in the ND Committee, the Environment and Health Committee of the European Parliament. In fact, While there are a lot of lawyers in Parliament, unfortunately there are very, very few medical doctors. But now let me get straight to the point of plasma supply, and the revision of the EU legislation on blood, tissues and cells. From my work as a medical doctor, I know firsthand about the importance and the growing clinical need for plasma-derived medical products. In many cases, we just don't have an alternative yet. That's why the fact of insufficient plasma supply in Europe is a cause for concern and a problem that has only worsened during the current pandemic. The upcoming revision of the EU legislation on blood, tissues and cells is therefore of great importance during these difficult times. Unfortunately, the European Commission is quite behind schedule. Originally, the legislative proposal was planned for 2021 and then postponed several times. And my latest information now is that it will be submitted in July. And I really hope we will receive the proposal before the summer break so that we can start to work on this important file in the second half of this year. Before talking about concrete legislative action, I want to draw your attention to a much more fundamental point. The altruistic donation of blood and plasma is so important, and we are thankful for everyone who decides to donate. Unfortunately, we have been experiencing a constant decline in donations, although around 300,000 patients in Europe rely on plasma-derived medical products. Many long-standing donors are reaching the age limit or are prevented from donating due to illness or some other reasons. At the same time, not enough young donors are filling the gaps. This is where we have to start. We need to increase the visibility of blood and plasma donations and of how important they are. Let's take away potential fears and raise awareness for the huge importance they have for the medical field. Starting in schools, for example, we have to reach the whole society to turn around this trend. Right now we are stuck in a very unsatisfactory situation where we have largely depended from plasma imports from third countries, mostly from the US, from the United States. While they are our allies, the pandemic as well as the Ukrainian war has shown that it is never a good idea to rely on vital imports from only one country. Additionally, by importing plasma, in many cases, we cannot guarantee the safety standards that we apply for in the European Union. At the same time, we have to analyze why the United States is so much more successful than we are. Why are they collecting so much plasma that they can even export plasma to Europe? I'm sure we can learn a lot from our American friends here, without compromising the safety of the donors. This always has to remain priority number one, by the way. I quickly want to mention two policy proposals that could help Europe to collect more plasma and that should be addressed in the revision of the EU legislation on blood, tissues and cells. First, we should rely on the technological progress instead of undifferentiated discrimination of certain donor groups. Not sexual orientation, for example, is important when it comes to blood and plasma donations, but the individual health status. Modern screening methods allow us to analyze the donations to make sure that they are safe for the recipients. Blanket exclusions of social groups are thus no longer necessary. This already enlarges the group of potential donors. Now my second proposal. My second suggestion has probably a much bigger effect. It is about the systems of plasma collection in Europe. Right now, 4 countries in the EU collect more than 55% of plasma. This is Germany, Austria, the Czech Republic and Hungary. What these have in common is that there is some monetary compensation for the time and effort of the donor. And let me be clear here, I strictly oppose a commercialization of blood and plasma donations. Allowing for modest monetary compensation, however, shows appreciation for the altruistic act and has shown to increase the number of donors substantially. The specific limit of such compensations should be up for a debate. Equally important is the fact that Germany, just like the United States, allows the coexistence of public and private sector plasma collection. With a strong regulatory environment and a strong safeguards for patient protection, this quickly promotes the collection of vital plasma. The lack of European plasma is one of the big challenges the revision of the EU legislation on blood, tissues and cells should tackle. Apart from that, The legislation also has to be updated to reflect the latest scientific and technological developments. After all, the two directives currently in force are almost 20 years old, and science already made lots of progress during this time. For all reform efforts, however, one thing is clear: the safety of the donors has always to remain the top priority. Now I wish you an interesting debate. Stay safe, and best wishes here from the European Parliament in Brussels, Andreas Glück.
Good morning, everyone. My name is Tomasz Kruszyński. You may have seen my name on some of the papers that were distributed throughout this conference. And it's my immense pleasure to host the first panel discussion of the day. As Ainhoa very eloquently put it earlier, yesterday we really focused on product availability, on plasma donation and collection. Today we are really going to focus on patient access. And patient access is, of course, a very multifarious phenomenon. You know, when we think of the care delivery continuum, we have what we can call formal access, and that's why we have Cesar Hernandez Garcia, who represents the policy, the appraisal, and the assessment of medicines. So that's where the formal access sits. But of course, with formal access, with policy, with legislation only, that's not quite enough. We also have the therapeutic access, so the appropriate use, the clinical use, the protocols and the guidelines. So we will also be hearing from two clinicians, whom I will introduce very shortly, as well as finally, of course, the relentless focus on patient voice and patient need. So we have also a patient represented on the panel. So without further ado, I will introduce our panelists. Dr. Cesar Hernandez Garcia, who is our wonderful guest from Spain, from AEMPS, which is, of course, the Spanish Agency for Medicines and Health Products. Welcome, Cesar. We have Professor Maarten van Hagen, who's an immunologist at Erasmus University and Erasmus University Rotterdam Medical Center. Professor Mark Stettner, from University of Essen, also a senior consultant neurologist. So we have both the immunology spectrum and neurology spectrum represented today. Of course, by far not the least and not the last, Jean-Philippe, who will be able to give us a perspective, not the usual perspective. We have been hearing quite a lot about immune deficiencies, but Jean-Philippe is himself a patient, but also a chairman of EPODIN, which is a European Patient Association for disimmune and neuropathologies. And finally, towards the end of our meeting, we will be hearing from Roberto Tana, a little bit of an industry voice to close off the proceedings, trying to bring holistically all of the issues discussed today to a close. So first, we will be, unfortunately, Professor Lieven Annemans, who will be speaking in a moment, couldn't be here with us personally. So we will have a short video of Professor Lieven Annemans exploring all of the clinical and socioeconomic value of PDMPs, of plasma-derived medicinal products in general. And then we'll move in with our discussions shortly afterwards. If we can play the video, please.
Hello everyone, I'm Lieven Annemans. I'm a professor of health economics at Ghent University, and I'm happy to be here with you. I would like to share with you some key elements of the report that Ventura wrote on plasma-derived medical products. I would like to start, however, with what I call the key principles of a good healthcare system. And those three principles are quality, solidarity, and sustainability. Quality is obvious. We want good healthcare systems to deliver the best possible quality of care to our patients and to our citizens. The second one, solidarity, means that two people with the same need also deserve the same quality of care. It's a human right. It's Article 25 of the Declaration of Human Rights that states that every citizen has the right for good healthcare. The third principle is sustainability. That means that if we still want to guarantee good care for everyone in 10 or 20 years from now, we have to make sure that we don't waste the money in the system, that we spend our euros and our dollars wisely. These three principles clearly apply for the PDMPs. Why? Well, first of all, quality, that's quite logic. We see that these products offer a lot of quality adjusted life years because they save lives, they improve the quality of life of patients, there are plenty of data on that. And also they have an important socioeconomic benefit then, because people can have a normal life, pretty normal life, can be very productive, can contribute to the economy. So the socioeconomic benefits of these products are huge. Solidarity, there we see an issue, because as I said, everybody who can benefit from this product should also have access to these products. And that means that we have to guarantee that entire chain from donor to patient. And there we see in that change already some disruptions, and we have to avoid those disruptions. All those who are convinced about the value of these products, and I think everybody should be convinced about the value of these products, should also be convinced that we have to avoid any possible disruption at any point in that chain from donor to patient. It starts already with getting the plasma. We see there that there is kind of an imbalance, because there are 4 countries that are responsible for more than 55% of the obtaining the plasma. And we see that, that this is maybe not sustainable. We know that we will need even more of these products in the future because of the demographic changes, and these diseases require longer and for a longer time treatment. So that means that we have to find the balance there, and that we have to find incentives that also more European countries can obtain more donors of plasma. It's not a coincidence that those 4 countries that I referred to apply clear incentives for their donors, and that's really very effective and good practice, and should be applied more also in other countries. Availability also has to do with money, of course, and that brings us to the third key principle, namely sustainability. And there we see that there are challenges on 2 levels. First of all, what we could call the formal patient access procedures, reimbursement. We see that not everywhere the reimbursement of these products is optimal. We need to look at what we call cost effectiveness. What is the cost of the products and what is their effectiveness? But we have to look at more. We see that more and more countries adapt their reimbursement procedures and criteria to bring in 2 additional elements, namely the medical need, and no doubt that the medical need is very high for most of the conditions that we treat with the PDMPs. And we also have to bring in budget impact. I proposed, and it's also written in the report, a concept which I call value-informed and affordable prices. That means that the price of products is in relation to the value that they deliver to the patient, but we keep there in the calculation also the importance of the budget impact and the medical need. And by doing that, we will see that we can really find that these products can be value for money in that broader concept. So we have to get away from the what some people call the cost plus price. Just give us your cost of your production and development, and that will be then your price with a little bit of margin. No, we have to pay for value. Value is of crucial importance, especially now in a world where we go to what we call value-based healthcare systems. And with that regard, I would like to point to 2 other elements that are also clearly written in the report. The first is cost containment measures. On first sight, it looks logic that, remember, given sustainability of healthcare systems, that countries try to contain the costs of care. However, there are 2 dangers. First of all, it might be very linear sometimes, so not making a distinction anymore between products of high value and products of low value. And second, it doesn't take into account the complexity of some of the products. We can easily refer also to vaccines. In many countries, vaccines are receiving an exemption of cost containment because they are complex to produce and because they have a huge societal benefit. So I think when we talk about PDMPs, that the same criteria apply, and we have to be really very careful with purely cost containment, which ends up sometimes to be really cost myopic, and that's not what we want. We want to keep that value always in the picture when we want to make good healthcare decisions. And that brings us to another element, that is tenders. Again, the same story. If tenders are purely based on price, then we get a race to the bottom of those prices, and moreover, we forget to bring in again the element value. So it's normal again that countries and healthcare systems organize tenders, but then it should be based on a logic that we call value-based procurement, that all the elements of the value are taken into account in the picture. And also that we have to make sure that when products are not interchangeable, that we allow several products still to be available to patients, that clinicians have the choice to work with those products. So it's very important that we pay attention to those issues. And that brings me to the conclusions of my story today. So first of all, I argued that we have to be very careful to avoid any disruption in that very important chain from donor to patients, and that we have to increase the number of donors. We will need more of these products in the future, so we'll need to increase and take measures to increase the number of donors. Second, when we deal with reimbursement, there should be more harmonized and more clear criteria that take into account the value of the products, the cost effectiveness, the medical need, and the impact on the budget. And third, we have to be careful with measures that only look at costs and nothing but cost, because then we completely forget the value and the societal impact of the products, and those need always to be part of the equation. In conclusion, I think there is room for improvement. I'm an optimist, and we have to have an open dialogue to try to improve indeed the current situation for the PDMPs. I invite everybody to read the report carefully. There is much more than I was explaining now in this very short speech to you, and I hope that you enjoy it and that it can help to improve indeed the access to patients, because that's the ultimate goal.
So I'm very grateful to Professor Annemans for this tour de force, has taken us through pretty much almost everything that was said yesterday, and it's a great interlude to today's session. So maybe let's start with the big picture, the more philosophical question. So Professor Annemans has sketched this wonderful triangle of sustainability, quality, and solidarity. But of course, that triangle is always at tension. The more we stress sustainability, the more we can compromise, for instance, quality. The more we push for quality, the fewer patients may be able to access it. So my question is to first Dr. Hernandez Garcia, as a policymaker, as an assessor, an appraiser of medical technologies, how can policy really balance this patient access, those three principles? What can we do at a local and European level to really ensure maximum equitable access to PDMPs?
Well, first of all, thank you very much for this invitation, and happy to share this time with my colleagues in the table and all of you. Let me reflect on a high level. I think that the diagnostic is good, to be first. I think that the starting point is a starting point that is not good for anyone. We have new medicines that are more and more expensive anytime. We have old products that are cheaper and cheaper anytime. Both things are not directly linked to the value of the medicine. So we have higher price for low value medicines and lower price for high value medicines. We have a pressure for early access. So, and I think this is important to be recognized, that it's not going to change. I mean, when I was in clinical practice 13 years ago, I probably knew more than 99% of patients that came to my office about medicines that are available and can be offered. And And now, I even working at a medicines agency, I sometimes get surprised by what patients know about what is being developed elsewhere in the world. So this pressure is not going to be lower. I think that the fact that we have this, we have this pressure for early access, but knowledge increases with time. So we, by definition, know more about medicines when there is an extensive use and long track of utilization in the health system. But the prices go down at the same time. So in the end, this is kind of difficult situation where we pay for uncertainty, we don't pay for the certainty. So, and this is what makes really difficult the starting point. And in the end, what happens is that these low-cost, high-value products are involved in shortages. And I have to say that 13 years ago, I mean, shortages and dealing with this issue and finding medicines in other countries to be imported in Spain was a minimum part of my activity. But now it's I mean, maybe 10% of my time is devoted to this kind. So the starting point is not good for anyone. And in the end, the outcome is a non-balanced system that we need to rebalance. And now we have a huge opportunity because, we have a huge revision of the legislation. We are involved not only in BTC, but also in the basic legislative acts that are going to be. The European Commission is going to propose a text by the end of the year. We are revising the orphan and pediatric medicine. We have recently approved, but we will be developing the HTA legislation. We have just put in place all legislation on clinical trials that are going to be entered. So we have I think it's a big challenge, but a good opportunity to rethink the entire system and to propose a kind of new deal. So sit around the table, everyone that needs to be involved, patients around the table, not the patients only in the center, but being part of the equation, and to examine what has failed in the system, what has make us reach this situation, which is not good for everyone. And I think it's important to recognize, and I will end with this, that this opportunity is not just for medicine regulation. Should be, maybe later we can reflect on this, but I'm pretty convinced that we are not going to solve everything just changing the regulation. So we need to have a wider view on this. But changing the regulation, and it's a good opportunity to make the European Union again have for a lively environment for life science, for research, for developing, and this is not only health, for sure it's health, but it's economics, it's possibility to my triangle is innovation, access, and sustainability, which is pretty much the same. And I think that we need to push for making possible that everything is aligned, so that it's possible innovation, it's possible access, and we need to work on that and to resolve the problems that I have mentioned before. And then we need sustainability for the health system for sure, but also for the medicines. Again, we cannot have policies in place that make the medicines which retain high value, cheaper and cheaper. This is not going to work. We need to recognize what is the floor and to try to pay accordingly to the use. And it's a big challenge, but it's a big opportunity also to rethink the entire system, because we need to this kind of new deal among everyone involved, and to put all align it so we can make it possible that innovation, access, and sustainability is not against one to each other.
Thank you so much, Cesar, for this very exhaustive answer. And I think you've mentioned two extremely important elements here. One, which is overarching the collaborative approach, the multi-stakeholder dialogue and perspectives, which gives substance to what legislation can do. Because legislation, as you said, in and of itself, is not going to solve the problem of either access or solidarity or quality. But from that sort of collaborative approach, it's quite clear that in Europe we have a lot of inequality and a lot of irregularity when it comes to many indications where PDMPs clearly have value, and evidently so, you spoke of evidence of value, but are still being used very much, ugly word, off-label. Would you say that maybe politically or from the regulatory perspective, we should really address that situation better? Again, listening to the patient, the impact that those medicines have on their lives, as well as clinicians.
Well, actually, we are involved we are chairing a group that is trying to make some work on how to repurpose all medicines to new indication, not led by the companies, which in the end have lost commercial interest in the medicine, but in the hands of the academic sector and universities, hospital, patients, so that everyone that has information and data to prove that something is valid can incorporate it in the label of the products. I would say for free, and maybe not for free, but without making this expensive development that regulator usually request for the companies. So we can benefit for the this field is much more in the hands of the academic research, and by bring together these two areas and make it easier the investigation, incorporating real-world evidence with quality not to be recognized by the regulation. I mean, break the divergence of clinical use and label of the products. I think that if we make it closer and we allow to have these products with extensive, for example, off-label use, make it possible that the indication is recognized in the label of the, and then that any company without commercial interest can take this new indication and put in the label. We may solve part of the problem and then leave the pure innovation without mixing one and each other, which I think is important because we need to separate. I mean, sometimes it's a big pressure to have all products with new indications. I mean, in the end, this plays against access if the price go very high, and we need to deal with this. And I think repurposing will be part of the new legislation for sure.
Thank you so much, Cesar. And I think that's a perfect segue to Professor Van Hagen, who I know can speak of the real-world evidence and real experiences of a clinician, both in, again, indications that are very well established, like primary immune deficiencies, but also those that are less obvious, like secondary immune deficiencies and other deficiencies. So maybe, Professor Van Hagen, I know you've prepared a little presentation to give us proper evidence and proper, if we can maybe pull it up, unless you would like to start speaking, or would you like to show your presentation first?
I'd like to make one remark first. Thank you for the kind invitation to give the presentation here and be part of the panel. I'm doing this work 35 years. And I'm an internist immunologist. I have also a degree in clinical chemistry, so I have also some lab experience and connection. So I'm always interested in the chemistry also of these molecules. What is hard to explain to policymakers and payers is the difference between a plasma molecule and a biological. For most of us here, it's quite simple, but not for everybody. Mm-hmm. And, we have a lot of biologics. It was an extreme breakthrough. I saw some different molecules during my career, which are really breakthroughs. Anti-TNF, for example, that changed the world. It's a biological, and in the beginning they are expensive. They have a certain price. And the point is we have a lot of biologics at the moment, more and more are coming up. And they are working tremendously. We have a drug against macular degeneration, to inject in the eye, otherwise you get blind. We have a new one against calcitonin gene-related peptide in patients with migraine, works in 70% in patients who have severe headaches. All these drugs are about the same price. And then I'm not talking about the checkpoint inhibitors in cancer. And a lot is coming up. They are very promising and helpful. It's really amazing how that works. And this development is going on. So now or later, we will face a problem in treating your patient because of the money. And with that regard, back into human mind, you have to look at immunoglobulin and immunoglobulin therapy. And most people, payers, etc., think they are kind of the same. And they are in a different price range. I think, but I'm not a politician, I never will be, probably, we will face a disaster at the end because we get so many drugs, helpful drugs, efficient drugs on the shelf, and we cannot prescribe them. Immunoglobulins, plasma molecules in general, are from a different nature. And that's, Jan Bult and I made a slide about that to explain the chemical drugs, the biologics, the biosimilars, which are a kind of the innovator molecule, looks like, but the glycan levels are different, and some have a little bit different function, and they are cheaper than immunoglobulin therapy, usually, but there are a lot of indications. So, looking at these drugs and looking at the prices and where we can use them, and I'm lucky in the Netherlands because for most indications we can use immunoglobulin therapy, so I'm quite lucky with that. But yeah, you cannot give it so easily to every patient because there are limited budgets. We know that. And with that back into your head, you have to keep in mind it will be compared. And we have to teach policymakers and etc. that it's different to extract molecules from plasma than to have a cell line that produces a biologic. And I think it's really important that they see the difference.
To really get it to the basics, to
Yes.
really get to the fundamental perennial issue. And I think that's to Cesar's point, this is where the multi-stakeholder dialogues really come in. Sometimes it is talking about the basics. And you've made a very interesting point, so maybe before we move to your slides, you've mentioned a lot of therapies that are quite invasive, that of course work on the immune system in oncology, but many of those therapies have unintended side effect, which is secondary immune deficiency. So what we are seeing now is, of course, a huge increase in clinical need for immunoglobulins. Are you seeing that in your clinical practice as well?
Yes. There are two points. One is in my outpatient clinic, I am responsible for 4,000 or 5,000 patients with a rare immune disease, immune deficiency, autoimmune disease, autoinflammatory disease, and allergies. And I have 9 internists who are taking care of that, fellows, PhD students, etc. And they are rare. So we are specialized in rare immune diseases, vasculitis, and what I already mentioned, immune deficiencies. So we opened an outpatient clinic for the side effects of patients who are using checkpoint inhibitors, because a lot of them develop autoimmune disease. Many times antibodies or a reaction against your endocrine glands. So you can develop thyroiditis or skin disease or gastrointestinal inflammation. And that's, that's really something new. That's one part. And then we have to take in regard the new drugs that are affecting B lymphocytes. B lymphocytes. And B lymphocytes are the precursors of plasma cells that produce the IgGs that you extract from the plasma. So the new therapies like CAR T-cell therapies, that attack specifically B cells or B cell malignancies affect also your normal B cells. So you get rid of your antibodies. So that's a new indication of treat patients with immunoglobulins. That's one part. In that line, like these anti-B cell therapies are very successful in the treatment of blood vessel inflammation, vasculitis, dangerous disease. And more of these drugs are coming up. The one we are using, rituximab, is only affecting B cells. The newer ones that are tested now, affect plasma cells. That's something new, because in the clinical practice, it's a kind of a hell to get rid of malignant antibodies. Antibodies that are causing autoimmunity. That's very difficult. Plasmapheresis, we are giving immune suppressors, but most of them do not work so very well. And now, because of cancer, bone marrow cancer, myelomatosis, cancer of plasma cells, will be treated with antibodies against plasma cells, anti-CD38. And rituximab do not affect your plasma cells, so they are still producing. And keep in mind, plasma cells live for 10, 20 years. And rituximab is only affecting more or less the short-lived plasma cells. So there is a line of research going on affecting the whole line of B cells, and probably very successful. So, but you get lost of your own production, or maybe we have to reset the patients, like you do with an autologic bone marrow transplantation, and see if we get rid of these auto-antibodies, the toxic ones, and that the B cell comes back again.
Professor Van Hagen,
sorry, I was too long.
No, thank you so much for this masterclass. I think we have learned a lot already. If I can ask you to maybe show the couple of slides, if we can pull them up, that Professor Van Hagen has prepared for us. I think they are a great extension of what you've already touched upon.
Yeah. So, sorry, I'm from the Erasmus MC. I'm also visiting professor in Chulalongkorn University in Bangkok. We raised a network with Indonesia, Philippines, Malaysia, Thailand, Vietnam, in working on patients with immune deficiencies with the help of IPPC. I'm also a member of the board of IPPC. And how to treat, how to help the people over there, do the diagnostics, and help them also with the therapies, because especially immunoglobulins are not always available there, or you have to stop at the age of 16. That is really, really something. It's actually the 70-year anniversary. 70 year. The first publication of Bruton, so probably we have a big party with IPPC and PPTA and etc. at 75, so we have 5 years to think about the party. But it's now 70 years of an immunoglobulin use. Actually, it came up in the 80s much more, but it was published in 1952 in a boy who had pneumococcal sepsis. And that's a lethal complication in patients with immune deficiency, and that works. And it was subcutaneously used at that time. It has been shown for a very long time. I stole this slide from Helen Chappell, a good friend of mine who's very famous in the field of immune deficiencies. That it was shown that immunoglobulin therapies work. So we're using that. In my clinic, we have 690 patients with all kinds of immune deficiencies, including autoinflammatory ones, and we are 370 or something on immunoglobulin therapy in a whole setting system with subcutaneously, intravenously, and it works quite well. And we look how many times they have an infection. So this is the part you know. This is the part you know. I want to share something differently with you. This is This is the ultrasound of a heart. This is the ultrasound of a heart. This is the vessel wall, of the chamber wall of the heart. And this is here, this is the wall. This is not working well. This is not working well. And this is a patient with a balloon pump and extracorporeal oxygenation of blood. A patient of 32 years is from my patient out clinic. This is a dying heart. This is a dying heart. This patient had COVID-19 and developed a dying heart 4 weeks later because of inflammation. And then you have to be very tough in your treatment. Here you see the heart again. Yeah, that's the. It looks a little bit different, but that's the technique. Here you see the chamber. So the chamber of your heart, where we look in, and you can see over here. This is quite better. Quite better after prednisolone therapy together with IgG, high dose IgG, 2 grams per kilogram body weight. This is an indication. 3 years ago, I never even thought about an indication like this, that we have this combination, to give this combination therapy, and this has a tremendous effect on the inflammation on such a patient. So a mild COVID-19, and very luckily not everybody has this. It's quite rare, but it's a lethal condition in whom you need the treatment of immunoglobulin therapy and prednisolone, and it's something I never heard of 3 years ago. We called it a multisystemic inflammatory disease in adults, and children have also this disease. And we like to have a count on you, because you are extracting these immunoglobulins and to treat our patients and have immune modulation. I do not go in detail. We like to have good immunoglobulins with enough idiotypes. And yeah, we are of course interested. Can you add something? Can you add? There's for example, I talked about rituximab for vasculitis. I talked about it. Yeah, very successful. But what about rituximab in the era that we have to vaccinate our patients against COVID-19, SARS-CoV-2? That's a problem, because rituximab is not a very good drug for when you want to vaccinate your patients. So, how to do? We love to have a preparation, for example, with anti-SARS-CoV-2 antibodies and give it in high dosage so we can use the immune modulation and also protection, not for the therapy, because it works more preventive. A lifestyle, only a little bit more. Is there a difference in lifestyle? Very interestingly, one of my PhD students published this. Do we have to select donors with a certain lifestyle? Smoking is decreasing your IgG level 1 gram per liter. It's very new. So your lifestyle have an effect on your immune globulin level, and we want to translate this also to our patients who are using immunoglobulin therapy. Or do we have to look at the genetics? And that's one of my last. We can look at all genes. This is the former study was in 8,000 normal people, and this in 830. Of which we have all the gene expression profiles to look how are these patients looking. And for example, I give you only an example over here, the level of immune globulin in your blood is related to how hard interferons are working. So we get more details how and what to treat our patients. So are we working with the pediatrics, immunology, laboratory, internal medicine, and close with my friends of IPPC. And I have to say it, we were homing IPPC, the IPPC meeting in 2023. Sorry for that.
Thank you so much, Professor Van Hagen. This has been I think with Maarten, Professor Van Hagen, we probably will need at least another session purely dedicated to your recent discoveries and everything that's so fascinating in a fast-changing world. But I think what's really significant is that every day, as you said, we are discovering new indications, new highly promising immunoglobulin therapies. And I think that's, again, something that is perfect link to Professor Stettner's specialty, which is neuropathology, so neuropathies. And maybe we can start with an explanation, not just about the value of immunoglobulins, but also about the difference in neuropathy, between immunomodulation and replacement therapy. If you can take us through, Professor Stettner.
Yeah, thank you, Thomas, for the introduction. Maarten, thank you for this brilliant talk. It was really nice. So if you ask me regarding the difference between neurology or immunology and neurology, I think the main difference is that neurologists are much more pedantic than immunologists. Since I'm a neuroimmunologist, I think I'm just in between. But to be serious, if you would have asked me this question 10 years or 5 years ago, I would have been saying, well, in neurology, we just use IGs to treat autoimmune inflammatory conditions. But as you mentioned, in almost every part of medicine, new drugs arise, and for neurology, it is mainly MS treatment. So up to now, we have 2 licensed drug B-cell therapies, ofatumumab and ocrelizumab, which is licensed for MS treatment. And as you may know, MS patients are quite young, so you start treatment in the age of 30, 40. So most likely these patients will have a long time of treatment, and the possibility for these patients to get secondary immune deficiencies due to the B-cell therapy is quite high. So to answer this question today, I should say, well, we have inflammatory conditions we are treating using IGs, as well as maybe in 10 years, but also already today, secondary immune deficiencies. But I want to stay with the inflammatory conditions. The one thing which is, you mentioned several aspects which make IG therapy unique, and this unique point is that it's a human resource, and the fact that it's valuable, and that it is valuable, and that it is limited, and human resource was quite aware during the COVID crisis. But the very unique selling point, to say so, is that it, on the one hand, treats immunodeficiency, and on the other hand, the same drug treats inflammatory conditions. And if you would ask me the question, how does this happen? What is the molecular mechanisms? I think we could give a talk here with 2 or 3 hours. There are many ideas how IVIGs work in inflammatory conditions. We don't know it exactly. Maybe it's Fc gamma receptor mediated. Most likely it is just a blocking of inflammatory cytokines. We don't know exactly. Maybe it's different in different patients and in different conditions. But in neurology, if you see the amount of IG used there, the main portion goes to inflammatory neuropathies. And on the one hand, this is GBS as an acute life-threatening condition. On the other hand, it's MMN and chronic MMN, more motoric, rare condition. And on the other hand, CIDP as a chronic inflammatory immune-mediated conditions. And the difference, you asked about the difference is also that in neurology, or I want to say in general, in treating inflammatory conditions, autoimmune conditions, we use much higher doses. In hematology, for secondary immune deficiency, we use something like 0.2, 0.3 gram per kilogram every 4, 6, 8 weeks. But in neurology, we indeed use up to 2 gram per kilogram every 3 weeks, up to this dose. And there was a just recently published study which suggests even higher doses. So we use high doses, and of course, the question is relevant: are we using these high amounts of IVIGs or IGs in general in an appropriate way? That's a question we have to ask, and that's what we are discussing right now.
Absolutely. And I think you've touched upon another important issue. So we're hearing about new indications being discovered, so the clinical need is increasing. But beyond the new indications, there's also established ones. For instance, you mentioned MS, young patients. They can have a lifelong treatment. So the extension of the treatment span is also putting an enormous pressure on what we've already been hearing, very fragile ecosystem of PDMPs. And then you mentioned, well, there's immunomodulation. I cannot quite explain, or you could explain, I'm sure you could, but it would take hours. So what would you say to a policymaker like Cesar? You know, it's a super complex issue. There is this mechanism of action that is incredibly difficult to explain. It's putting a lot of pressure on the ecosystem, but of course you want all your patients to have the treatment. And Cesar will probably need to, at some point, look into it and say, well, I need to allow for that. I need to make a statement or recommendation for reimbursement. So what would you advise? You know, we've heard teach the basics to the policymakers, but what would be your advice to the policymakers? You know, the title of this session is Beyond Legislation. So what else can we do to increase that access?
Yeah, first of all, I want to put the spotlight on the problem. So usually as a physician in Germany, you don't ask the question if a drug is available. So for me personally, I've lived quite a long time in Western Africa and worked there in hospitals. I'm still organizing some hospitals there. And so for people working in African hospitals, it's just the daily routine to ask the question, is this patient sick enough to give him this expensive drug, which is limited, because you just have 3 doses of this expensive antibiotic. And in case if this child is not sick enough, you choose another antibiotic, which is maybe cheaper and which is available. So in some regions of the world, you are used to this question. And COVID crisis showed us that it is not too far away. So in some hospitals in Germany, the question was important, is this patient sick enough to give him IVIGs, or should we rather give him something which is maybe efficient, also efficient, but maybe has more side effects? And that's one of the problems with IVIGs. We have a drug here, and that is the difference. You mentioned rituximab and all the biologics we have, which are also immune modulatory. These drugs have relevant, or maybe, or most likely all of them have relevant side effects. There's a large number of possible side effects beside the immunodeficiency. And on the other hand, we have IVIGs, which are also used in inflammatory conditions with very little side effect, or let me say, with a good balance between efficacy and side effects. And so in the case of a leg, you switch to another drug, which is also maybe efficient, but has more side effect. For GBS, I could mention plasmapheresis. And so I want to draw a line under it. It was for physicians in Germany to decide regarding availability. And from my personal point of view, it is not our task to decide regarding availability. And I would also say it is not our task to decide regarding financial aspects in general, because we should decide regarding regarding the question, what is the best for the patient?
I think Cesar would like to comment.
Yeah, just a quick comment. I fully agree with you. I mean, my job is that those kind of decisions that on the patient healthcare professional relationship only are based on that clinical ground. So forget my job is to provide the rules and the tools and the medicines, so we can exclude from the equation this kind of or this. I mean, unfortunately, I think that we have done this system extremely complex for everyone, and in the end, we instead of coming back and rethink the things, we are making it more and more complex. And we need to de-escalate this somehow. I mean, clinical decisions will be made at the clinical basis without any other thing. I mean, which is the best thing that I can. And then sometimes we can, raise these questions at the highest level with the clinician to say, okay, what is the root? But I mean, how do I envisage the system? I mean, we need to solve that. So it's not your problem, for sure not the problem of the patient. It's my problem. Fully agree.
Thank you so much, Cesar. And I think it's a good point now to mention that both Professor Stettner and Professor Verhagen are part of the advisory board, and we are working very hard precisely to try and simplify the framework that would indicate where immunoglobulin use is appropriate, what conditions, what criteria to be taken. So watch this space. It's probably coming in a couple of months. But Professor Stettner, you mentioned availability being a perennial issue regardless of the COVID crisis in some countries, like in West Africa. So of course, it would be wonderful to hear from the patient, both in and out of crisis, what is the impact? First, the positive impact when you receive the treatment, but also what is the dramatic impact when you don't have the treatment, either, again, because of COVID or for whatever other reason. So, Jean-Philippe Pinson, Chairman of Pathogen, over to you.
Okay, so thank you, Thomas, for this question, and thank you for the invitation. Well, for patients, maybe just a few words first, just to say that Pathogen is a coalition of national organizations from Italy, France.
I think you're not audible. Maybe I can give you mine.
Okay.
No.
Just microphone, maybe?
You cannot move.
Microphone.
Oh, perfect.
Yeah. Thank you very much. So I just said I thank you, and I thank you, the organizer first, and for this wonderful congress. I'm very happy to be here and to share with you the patient voice and the patient vision of the global system, which is very difficult, very complicated, and we all say that. Just before, if you agree, I just would like to say a few words, just to say that Pathogen is a coalition of several organizations, just for you to know who I am. It's a coalition of national organizations from Spain, Italy, France, Romania. I hope I don't forget someone. Well, just to share with you one or two numbers. 1.3 million people suffering from these immune inflammatory neuropathies worldwide. This is number from official number from Orphanet. And another number, 580. 580 is the number of donation that a CIDP patient, in average, a patient who needs to be treated every 4 weeks for 2 grams per kilo around. So we need a lot of immunoglobulins when it works for patients, and that's the first point. You said, Professor, many things about inflammatory neuropathies, but there are several families, of course, and for us, treatment access, immunoglobulin access is crucial, because we didn't say that, but almost 5 to 8% of patients suffering from GBS, Guillain-Barré syndrome, are dying from this condition. So it's a reality in 2022. So we have to keep that in mind. Well, of course, it's important for patients. I'm a CIDP patient myself. I've got 53, and I've been diagnosed when I was 30. My wife was pregnant. It was, of course, for me, it was very difficult. I was at this time a registered nurse in an emergency department. So, of course, it was for me the opportunity to rethink the work life. It's not an opportunity. I didn't have many choices because I was losing my abilities, to use my hand. I was losing my ability to walk. So I had to think differently, of course. And I've been diagnosed in 6 months, which is not a lot, in fact, because in France we made a survey, and sometimes it can go to 16 years before to be diagnosed in some cases when the disease is difficult to diagnose. I don't blame, of course, clinicians, but I know it's very difficult to diagnose sometimes. But 16 years, it's too long for patients. And so I've been treated firstly by IGIV, and for me, I'm not here to make advertising for immunoglobulins. For me, it was spectacular because I've got a specific form with a conduction block. So it was very important for me because after that, this first infusion, I had been able to use my arm again, to walk again, and to finally to have a normal quality of life. So to answer to your question, sorry, I'm maybe too long. Of course, for patients, it's very critical to be treated because, as I mentioned before, immune-mediated neuropathies are disabilitating. I mean, you are losing your physical autonomy, and when you've got a treatment that can restore this autonomy, your life is different. When you can shave yourself, when you can dress yourself, when you can cook yourself, and life is different. Especially when you've got 30, when your wife is pregnant, when you think you're going to be a young dad, your life is different. So for patient, actually, it's maybe we'll talk about that later. But of course, it's a problem not to be treated because if this type of treatment can maintain your autonomy, it's important to have a regularity in treatment, and especially in our disorders, because if you are treated every 3, 4, 6 weeks, it's important to be treated regularly, except when the disease, except when there is an evolution of the disease. But usually, it's important to be treated regularly. So when you have to wait for 1 or 2 weeks before to be treated, your life changes radically and rapidly, in fact. And this is spectacular in the bad way, because you're losing your ability, your autonomy ability, and you stop your capacity to work, you stop your capacity to shave yourself, you lose your autonomy. And for patients, it's a nightmare. So actually, it happens all the time in many countries, in Europe. So maybe we will talk about that later, but shortages are a nightmare for patients, of course.
And I think you've used a very, very important word, spectacular. You know, we are used to a lot of innovative medicine having incremental effect, whilst in your own words, you know, the effect of immunoglobulins on this immune inflammatory neuropathies is spectacular. As you said, it immediately alleviates disease-adjusted life years. I prefer DALI to QALY.
Yes, it's crazy. I don't know how to say that in English, but it's like montagne russe. I mean, your life is like that. You're losing your autonomy, and after being treated, you're restoring your autonomy. But the idea is to be in a regular manner autonomous. I mean, so I can't say any more about immunoglobulins. Of course, we could talk about the side effects, because sometimes you can have side effects for patients. That's why we talked about that yesterday. It's important to have several brands, just to be sure that one brand will be well tolerated than another one.
Absolutely. And Jean-Philippe, you mentioned something again that triggered me, because we keep talking about patient access. And patient access we immediately equate with access to medicine. But you mentioned something that I think we sometimes miss, that patient access is a continuum, and diagnostics is an incredibly important element of it. And maybe yourself, and as well as Professor Stettner, Professor Van Hagen, you could comment on the need to improve diagnostics, or maybe to introduce risk assessments, predictive diagnostics, screening, and that's probably an issue for also legislation and policy, not just a clinical practice. Jean-Philippe, do you want to comment? Because you did say it can take 16 years.
Yeah, diagnosis is a key element, of course, for patients, and we know it's difficult, and we are working at the European levels, especially with European Reference Network on this question, to raise awareness for general practitioner, who is usually the first doctor that you met, and sometimes it's just important to make a neurologic examination, a simple one. You just have to see several nerves and to see, okay, there is a problem. I need to address this patient to a specialist. And if you go through the first element with the general practitioner, maybe it will improve the diagnosis at the end. But sometimes it's not enough, because we are talking about rare diseases, we are talking about specific diseases, and we have to meet a real expert in this domain.
Absolutely. I think César, regarding diagnostics, how much can a policymaker really influence the system? Because we'll probably refer very quickly to Professor Stettner also about this whole referral process from GP when the patients reach you and how. But what can we do on the legislative or more than legislative level to improve the entire patient pathway?
Well, I think that this wider perspective is really the only one you can take. I mean, you need to diagnose, you need to, and being part of a medicine agency, this is probably not expected from me, but there are many other things to do besides medicine. So sometimes the competitor for a medicine is not another medicine, it's cares and physiotherapy or other things like that. And sometimes the immediacy of having a box with something that you can take is he's competing with maybe other health strategies that may be eventually have more sense for the patients. But definitely this is a kind of change that starts with symptoms, diagnosis. What we need, equality or equity is something that is around access. I think it is important to understand that equity is not just the access to the medicines, is to reach a given outcome. And sometimes clinical practice viability is wider, even within a hospital. And I remember when this is a joke, but it's not a joke, it's real, but 20 years ago, if you have uveitis and went to an office, you have always tuberculosis. It doesn't matter. And if you go to the other office, you are more likely to have autoimmune diseases. So, in the end, individual practices have more impact in equality than maybe this, bigger policies of access. But definitely, it starts from the detection, diagnosis, access to treatments, and outcomes, which involves more than only medicines.
Absolutely, and I think what you are referring to is what we very often refer to as value-based healthcare, which is sort of a true-pronged approach. One is the logistics, which is care integration, making sure that the referral process is seamless. But the other one is outcome-based control, really looking at patient outcomes and not the volume of interventions.
And not directly linked to the price of the medicines. We now say, okay, we are going to measure outcomes. And that's nice. We need to measure outcomes in clinical practice, but not linked to the price of the medicine, because otherwise we are justifying a high price for the medicine. So let's include measure of the outcomes and make this an end-to-end process. So we start with the initiation of the symptoms and finalize with the outcome of the health outcome of the patient.
I'm very painfully aware that we will be running out of time very shortly. Maybe a very short comment from Professor Stettner about the diagnostic issue.
Yeah, exactly. I think I just want to make two small points here. So to improve diagnostics and to also, in the end, then to improve therapy, I think it's necessary, and that's a common life experience. If you do something regularly, you do it better than if you just do it once a year, and that's the same in medicine, in every field of the medicine. So I would say we need more specialized centers which do have experience for a common condition or for a common disease, for a specific disease. In CIDP, in MMN, that's always the same, and that improves quality on the one side, but this is also efficient economically, so it's cheaper to treat in a center where it is treated regularly for the society than if a single doctor who does it once in a lifetime, who needs more examinations which are not needed maybe. So it's cheaper and the quality is better. That's one point. If you centralize it, if you have specialized centers, that's one point. And the other point is that we do need registries for the rare conditions. So if you have a condition which is rare, it's just not possible to have a randomized clinical trial because you don't have the patients, because it's not ethical, because the industry is not going to pay for this study, because in the end there are not enough patients to be treated. So for these conditions we do need registries, and that's something we could do on on a European level quite easy if there is the willing, or if there is the if there would be the money to finance these registries. So these 2 points are important for me.
Absolutely, and I think that's a perfect call to action, right? Creation of the pan-European registries. There are so many initiatives we've heard yesterday, I'm sure we will hear today, that are pan-European and require solidarity and require collaboration. You know, we've started with Cesar saying, you know, policy is all about collaboration and dialogue, and we are not so much yet ending because we will move to Roberto, but we are also accentuating the need for collaboration also in terms of data, evidence generation, registry creation. With that in mind, I would love to invite Roberto Tana to give us a short presentation. We talked a lot about solidarity and we talked a lot about sustainability from the policy perspective. Yeah. So it's time to talk a little bit about the quality and the uniqueness of PDMPs. I know many of us here are probably aware of it, but Roberto prepared a bit of a tour de force from the industry perspective. Over to you, Roberto.
Yes, thank you. Thank you for inviting me. Can you hear me well? Yeah. Okay, perfect. Okay, I would like to start from the end, from the conclusion, and basically it's very simple, straightforward. We need more plasma, and especially EU needs more plasma. This is a campaign that we started a few years ago, before COVID. This is the website. You can find a lot of information on the website about the campaign, and now is more and more important. And I would like to explain just in 3 points very quickly, because you already saw many of the slides, why it's so important. And why we need more plasma. The first point is the unique nature of our therapy. PDMP are a unique class of therapy treating rare, debilitating, as we just listened, sometimes life-threatening disease, and everything is derived by human plasma. So the real unicity, differentiation point, is everything is coming from plasma that is a very scarce resource, unique in nature, and that cannot be artificially reproduced. Everything is coming from a voluntary donation. You cannot force people to donate. And so it's really the key point, the key differentiation point of our industry. Out of the same liter of plasma, we can derive different therapies. We have been discussing today about immunoglobulin. I try to put here on the slide some condition treated with immunoglobulin. This is a snapshot from US of last year. And you can see that 30% is for primary immunodeficiency, that Maarten explained very well. Almost 20% is secondary immunodeficiency. And we discussed today how it's more and more important this kind of indication, because some disease or some therapy suppresses the immune system. So you need, for a period of time, antibody, you need immunoglobulin. 40% in US is on neurology. So it's really increasing the utilization for this kind of disease, because as Mark explained, you have no 0.2 grams per kilo on kids. You have 4 or 5 grams per kilo on adults. So really the usage is completely different. And then we have other indications, some of the off-label that we discussed today on hematology, transplant, rheumatology, etc. But there are not only immunoglobulin. Don't forget that we have albumin from the same liter of plasma. With our technology, we are producing albumin, we are producing clotting factors, C1 esterase, alpha-1 antitrypsin, and other molecules. Everything coming from the same liter of plasma. The second point is the process and procedure. I would say, as a personal note, is a nightmare. From a logistic, operation, quality, regulatory, and probably I'm forgetting something standpoint. Because in standard pharmaceutical, we can have a product in a month. In our industry, we are talking from 7 to 12 months from the donors to the patients. So it's really a long journey that starts with the donation. Then we have 60 days of inventory hold, look-back procedure to test. Then we have to move the product generally from US to Europe. It takes another month. And then we have the fractionation, the purification, the filling, the release. It's really a long process with a different step and different actions. And if something goes wrong in the middle, this disrupts all the production, and we can have a delay and an issue. So appropriate planning is really a key for the industry. And because of that, even the cost structure is completely different in our industry. Because as you can see, it's a very complex and labor-intensive. And so basically in the standard pharmaceutical industry, the production is like 14% of the total cost. For us, considering all the process and the plasma, we are almost at 60%. So it's a very long, labor-intensive, capital-intensive process. And this is what will really differentiate our product from the standard pharmaceutical. Then I would like to talk about what happened with the COVID pandemic, because this was really a shock from the industry. This is quite a busy graph, but I try to represent here the 2019 on the left. This is the monthly collection in US of, this is PPTA data, is a million liter collection per month. On the left, you can see 2019, where the industry collected around 54 million of liters of plasma out of around 70 million total in the industry fractionated. So almost 80% of the volume is coming from here. And you see 54 million liters with a monthly collection growing from 4 million up to 5 million liters per month. And then we got COVID in 2020. And you see the dramatic reduction in some months, especially in April, May. You remember the lockdown was a very dramatic situation across the world. These are US data, with the collection going down 50%. And then there was the miracle of the vaccine, because at the end of 2020, we got a vaccine. So you can see collection was ramping up, but then unfortunately, we got the variants. First, we got the Delta. Second, we got the Omicron. Then in the US, there have been a lot of financial stimulus incentive, and there was an economic rebound that was not so incentivizing the donation in the state. And so at the end of the day, in 2020, we lost 20% of the volume. 10 million liters disappeared from the market. In 21, everybody was expecting a recovery, but that was not the case. Overall, the volume increased 1% versus the previous year. So again, the industry lost 10 million liters of plasma. You see 53.5, 43.5, 43.8. So basically, no recovery. Today, we are seeing that already some industry, some company is claiming to have come back to pre-COVID level, thanks God. So recovering with the collection. But anyway, don't forget that will take 7 to 12 months to see the product into the market. So unfortunately, we have to struggle again for some months. Check me with the time if I'm okay. And then this is my last slide. I would like to say then we talk about the unique nature of our product. We talk about COVID, and now is the focus, the deep dive in Europe. In Europe, we rely 38% from US plasma. Probably you remember from Matthew yesterday, there was some different number some years ago, because there was 15, 20%, and then it got to 30, now it's 40%. Why is that? Because the demand is growing faster than the collection. So every year, we are more and more dependent from US plasma. First point. Second point, the collection in Europe is concentrated only in a few countries. As you can see here, this is again, Matthew, thank you so much, from MRB data, that Austria, Czech Republic, Germany, and Hungary are self-sufficient, so they are able to cover their own demand and to provide volume for other European and international market. While you see the big giants like Italy, Spain, UK and France that really rely on commercial product. We know pretty well in Italy the situation, and the self-sufficiency is around 70%. So we need to buy commercial product the 30%. If you can see Spain and France, we are below in the 30-50% range. So really, they need to buy product coming from US, from different kind of system. UK, we discussed it yesterday, was a really interesting case, and we look forward to have this new plasma coming to the industry after the removal of the ban. And on the left, there is the plasma, the supply. On the right, there is the consumption per capita of IG. And this is very interesting because this is an average, of course, so we consider all possible indication. And you can see that there is a huge inequality between countries. So we are talking about the same region, Europe. From epidemiological data, the incidence prevalence, we should have more or less the same number of patients per million inhabitants, but the utilization, the consumption is really different from one country to another country. In the US, it's higher than 300 kilo per million population. Here you can see Switzerland, Belgium, Denmark are above 200 kilo per million population, and there is several countries in the 170, 180. Germany, we are in Germany, 125, UK 100. The average is 80. What I would like to focus here is that there are a lot of countries below 80. A lot of countries where basically patients cannot have access to treatment. Because if you have 10, 12, 20 kilo per million inhabitants, meaning you are not treating the patients, just emergency, no prophylaxis, nothing for neurological disease. And this is really the key point, the key call to action in order to provide a broader reimbursement coverage and a better access to all those patients to our therapy. And if this happens, again, we will need more product, and again, we will need more plasma. And this is just my last comments. Thank you.
Thank you so much, Roberto. Thank you so much, Roberto. That has been, as always, extremely eloquent and took us through the full circle from plasma back to plasma and the need. But I think, maybe we can move now to sort of a round of conclusions. I would love each one of you to maybe spend no more than a minute, I know we are a little bit past time, to give us some of the calls to action. We have heard a lot about collaboration, about dialogue. We have heard about the need to look at patient access from the patient journey perspective, from the entirety of it. We looked at value-based healthcare and assessing value. But maybe let's start with the terrifying picture, the inequality between countries, and maybe, Jean-Philippe, you could comment from a perspective of a patient yourself, but also you represent patients. You hear those dramatic stories from countries like Romania, we've seen, that are dramatically underutilized in terms of IgGs.
Yes, thank you, Thomas. Of course, it's a problem. This is the main problem, the inequality of access in Europe, actually. Yeah, a call to action, of course, to collect more plasma. We know it's a complicated issue, and maybe it's not enough to say, okay, we have to compensate the collect of plasma, because it's much more complicated than that. And first of all, in Europe, especially, we have to measure that we are working together in we have many cultural countries, different countries, I mean, and it's not easy to speak with a French the same way as a German, the same way on a Spanish man, and etc., etc. So, but what we can say that a call to action to collect more in Europe, of course, but maybe a call to action to have a better repartition, because if you see, for example, Czech Republic, this is one of the first contributors in Europe, but when you see the access for patients, it's one of the lower. It's a problem. So we have to have another discussion. Of course, we will have another roundtable on this question, but I think it's important. And maybe just to finish, sorry for that, but another number from Romania, 2.2. 2.2% of patients suffering from CIDP had access last year. This is our friend from the RBNP from Romania, the Romanian organization. 2.2% of patients had 4 infusion, CID patient, had 4 infusion in a year, last year and the year before. It's crazy when you think it's in average 12, at least 12 infusion a year. And beyond, it means that 98% of the patient don't have access at all. So, of course, we have to work at the industry level, yes, at the European level, mostly probably, and at the national level with the national authorities. Health ministry are, of course, key elements in this panorama.
Thank you so much, Philippe. César, maybe let's move to you. Some closing remarks, recommendations.
Coming to the last point, unfortunately, it is not just access to the plasma products. It's more than that. So Romania and small countries in Europe have difficulties, and you know, Europe has been built around solidarity, and we need to make the effort to everyone, the industry also, that these countries may have the product, you know, at affordable. Because the problem with Romania, with Bulgaria, with other countries, is not just access to the medicines. There are more fundamental things that we need to share among us as Europeans. But coming back, this is not just regulatory policy. This is not just price and reimbursement. This is also involves industrial policies, and in the end is the economy. So we need to build this transversal view and not consider that we are just making the best cost effectiveness choice, because this may have many implications. We have seen this with the vaccines. We have, I mean, a lot of vaccines because we decided to build a huge production capacity for that. I mean, with this kind of medicines, unfortunately, we have these problems that have been explained very nicely, and we need to increase our capacity to have the plasma collection at a level that it is not anymore a problem. Then we need, for sure, that the clinicians should do the work with it, and we need to provide the supply that is minimum for that, I mean, enough. Not minimum, enough for that demand. And then we need to revisit our tender policies. I think that we need to consider, I mean, for example, in Spain, we have published a list of strategic medicines, for sure, immunoglobulins are among that. And this should imply not only, I mean, benefits from the regulatory point of view, but also, you know, highlight the importance of these molecules from the industrial perspective. So maybe some may put some incentives to make this easier, but also to the price and reimbursement decision makers, because and even those that purchase this at the hospital level or regional level. I mean, it is important that we understand, and this is my final sentence. I mean, for me, it is difficult to have sometimes supply under the normal conditions. But if I go to the markets and look for other products in other countries, I mean, apparently everything is solved. So apparently the problem was the price, apparently. So, I mean, we need to solve this, because in the end, let me say something that is very crude, but the product is going to those that may pay more for the product, and it's not going to those that pay less. So we need to balance this. And again, I think that we have a big opportunity with this huge change in the legislation in Europe to make it, more easy for everyone. And for sure, leaving aside the clinical decision that should be taken in the appropriate level without taking into consideration other aspects.
And I think you've made a point that previously wasn't made, that pricing can be very cost myopic if we don't treat high-value medicines as priority.
Because we don't have this transversal vision. I mean, we sometimes think that the policymakers is just price and reimbursement, and this is the only part of the pharmaceutical policy. And the pharmaceutical policy is wider than just that.
Fantastic. Well, let's now hear from the clinicians. Maybe, Mark, you can start.
Yeah, I don't want. You said 1 minute, right?
Ideally. I mean, we've already had a benefit of starting early.
Exactly.
But
So I don't want to talk about pricing. I just want to mention one point why it is so important to find a solution in this difficult aspect of availability. Why is it so important compared to other drugs? You know, it's a human resource, and if it comes to us in small bottles with a nice layer and well designed, it doesn't make us aware that it's a human resource. It comes from humans and it goes to humans, and that makes it our obligation to supply enough for everybody who needs it. And if I'm saying us, it means it is the obligation of the society, of the donors, it is the obligation of us as physicians and of the policymakers and of the industry to supply enough of this human resource to treat everybody who should be treated.
Thank you so much. That was very perfect in a minute and proper punchy. Professor Van Hagen.
So I take the next 30 minutes for...
Indeed.
No, I think the most important statements are made. I think that we have to realize 2 points. And one is that there are still a lot of indications, potential indications we do not know, because we didn't perform the studies. And even blame me, I'm treating patients with an immune deficiency. We are calling that now immune dysregulation. Why? We know the genes, and these patients have an immune defect, infections, but have also autoimmunity. It took decennia to know what is happening, and we know now many more genes. So there are no studies, in my knowledge, to treat patients with an immune deficiency, immune dysregulation, with high-dose immunoglobulins. They are treating them with low dose, what you mentioned already, Mark. And even that we didn't do. And in certain autoimmune diseases, I think that can play also a role, but luckily there are also null drugs coming. That's also an issue, because we cannot try everything, but there's still a role over there. And at last, I like very much the personalized medicine. And we can and have to learn much more from that. We know now many more genes, more than 500 in immune deficiencies, but also in other diseases. And we have to look at the pathways in the patients, and maybe in the donors, that I showed that slide, to adjust the dosage of drugs generally, but also immunoglobulins. We extracted 17 genes that are related to the degradation of immunoglobulins by the neonatal Fc receptor, but do not go in detail. That will be the future. Genetics, proteomics, in the patients, that will be to adjust and to focus more on a more efficient therapy.
Another very important point, personalization. So not just the provision of care, but provision of care in a very specialized and highly effective manner. Thank you so much, Professor Van Hagen. Roberto, 1 minute.
1 minute, okay. We've been discussing before what is your job. what is your work. I think from the industry side, our work is to produce those therapies. We did a tremendous investment for increasing the collection, because yesterday we have 2 sessions when we highlighted the number of centers that have been opened last year and the year before. 100 centers in 2020, 100 centers in 2021. And every center in the US costs millions of dollars. So the industry did a tremendous job, a tremendous investment in order to increase the collection. But in Europe, we need a change of law. In Europe, we need a change in the legislation. We need that some countries start to do something. Yesterday, there was in the first panel discussion in order just to move even in Europe and to start to change things, because we cannot rely only on US plasma. 1 minute.
Fantastic. Thank you so much, Roberto. And I think, there's a universal dictum that healthcare needs are infinite, resources are finite, but I think it is acutely and dramatically true about PDMPs, more so than any other healthcare resource. So thank you so much to all the panelists. It's been a fascinating discussion and a tour de force through clinical, socioeconomic, psychosocial, but also humanistic elements of healthcare and provision of patient access. So hopefully it's a good interlude to all the future discussions today. And I thank also all of you in the audience for being patient with us. We have gone slightly over time, but hopefully it was worth it. Thank you so much, and hopefully we can discuss more.
Good morning, ladies and gentlemen. Welcome to this session, which is set to run from 11:30 to 12:45. I'm Faraz Kamani. I head up Global Communications at PPTA. This session is on the uniqueness of plasma, a perspective for an essential differentiation from blood. I'm very aware that I'm standing between you and lunch, but this is going to be the best presentation of the entire conference. So, to start with, we know the EU is revising the legislative framework governing plasma and its derivatives. Plasma is a blood component, but what we need to do is to define it precisely what it is, to differentiate it from blood. That is essential for the industry, for patients, etc. So our discussion today will focus on, firstly, legal definitions, what we need to see in the forthcoming legislation, definition of plasma for manufacturing, and without that, we continue to have the uncertainty that we have today. The revision itself will provide us with an opportunity to address that type of uncertainty and provide all the clarity that we need as stakeholders. This, in turn, will lead to better global cooperation. So, firstly, I would like to introduce you to Dr. Bita Bakshay. She's a lawyer, specialist solicitor for medical law since 2006, and what is absolutely superb is that she concentrates on German and European pharmaceutical law, law regulating blood and blood components, tissues and cells, and biotech law. She's published millions of things. She's degrees from the University of Bayreuth and Erlangen-Nürnberg, and there she is, sorry. I'd also like to introduce you to Tom Brisselmans, who is appearing virtually somewhere above my head. Voila. He's scientific administrator at the EMA, Quality and Safety of Medicines Department, the Inspections Office. He seems to have studied at every possible university in Belgium, University of Antwerp, University of Ghent, University of Brussels, University of Leuven. Highly qualified man. So, but with that, I would like to invite Bita to kick us off.
Yeah. Well, hello to everybody. Thank you, first of all, for the invitation. And I'm really pleased as a lawyer to give you a very short overview of the European Court decision of 2014 2014. And it was, well, I will try not to bore you with any paragraphs or articles or something like that. And the parties of the decision were Octa Pharma France, Société par Action Simplifiée, which is a kind of joint stock company. In Germany, we would say Aktiengesellschaft. And the opponent was Agence nationale de sécurité des médicaments et des produits de santé, which is the French drug agency. Well, I don't know whether Jean-Philippe is still here. I have to be careful because he's engaged in this authority I have seen. And I would like to start with some definitions. You might be aware that we do have some definitions in the European Pharmacopoe and in the Directive 2004/33. And the main point, and this was the main issue between the parties, is that the definitions we do have, they do not help to clarify the scope between the two directives. We have two pieces of legislation at the European level. One is the Blood Directive, 2004/23, and the other one is the Community Code, the European Directive 2001/83, which is the European Pharma Codex for any medicinal product. And plasma-derived medicinal products are somehow just in between. And this was the reason why we had this dispute, first at the National Court in France and later on at the European Court of Justice. So the Pharmacopoe monograph 853 is the one on human plasma for fractionation. And we do know it's a liquid part of human blood. And it is intended for the manufacture of plasma-derived medicinal products, which seems to be quite clear. Then we have a definition in the directive covering the technical requirements for blood and blood components, which says that plasma means the liquid portion of the blood in which the cells are suspended, and it may be used for the manufacture of medicinal products derived from human blood and human plasma. So these definitions do not make clear whether a product, for example, in this case it was plasma-SD, falls within the scope of the Community Code or the Blood Directive. You know, the Blood Directive is the one of 2002/98, which regulates the collection of whole blood, but also of blood components and especially of plasma. And the most important thing is that it doesn't matter for which intention the plasma is being collected. And then we have the Community Code. It's the legislation for pharmaceuticals, which means for medicinal products in general, including, of course, also plasma protein therapies. And the main dispute between Octa Pharma France and the French agency was the question whether plasma-SD is a label product and falls within the scope of the Blood Directive, or whether it has to be treated like a medicinal product with a defined shelf life, and then the Community Code has to be applied. And the main ruling of the court was the following. They said that plasma, which is prepared by a method involving an industrial process, comes within the scope of the Blood Directive only with respect to its collection and testing, and within the scope of the Community Code, which means like any medicinal product, with respect to its processing, storage, and distribution. And the court distinguished between these two directives and their scopes. And the main point was that the French court later on has to decide whether plasma SD at all is a medicinal product or not, and whether it involves an industrial process. And yeah, my personal opinion as a lawyer, we all know that legislative provisions are not that easy to read, to understand, and of course they must be as clear and as simple as possible. But at the same time, we do need accuracy in the EU legislation and in any national legislation to have less discussions with authorities and later on less court decisions, not only on the European level, but also on the national level. But yeah, maybe the lawyers don't have to do anything later on if anything is so easy and so clear. But I really think that the present legal situation might not meet the needs of the parties which are concerned in the field of plasma-derived medicinal products. And the next question might be the following. We do need to know whether it is a medicinal product at first, and then we need to know when a medicinal product can be regarded as having been prepared industrially or manufactured by a method involving an industrial process. Well, the participants here from the industry might say it's quite easy, everything we produce is an industrial process, but it really isn't that easy from the legal point of view. We had another court decision of 2016, and they had to decide whether a special process was really prepared industrially or manufactured by a method involving an industrial process. And the court made clear that the understanding must be quite widely, and any preparation or manufacture involving an industrial process must be included. So the court tried to state what the characteristics of an industrial preparation are, and the characteristics were, for example, means of production used or quantities produced, succession of operations, and whether it is a standardized product or not. From the point of industry, I think it's no question. And the next question was, of course, is it be stocked and sold wholesale? And do we have a large scale or serial production or not? A production in batches, of course. And I think that plasma-derived medicinal products do meet these requirements. So we've already heard that in July there might be a new draft regarding the field of the blood directive, maybe the community code. But if the blood directive should be revised, it really might be the occasion to clarify the scope of the blood directive versus the community code. And this should be, of course, in line with the judgment of the European Court decision from 2014 in the case of Pharma versus the French authority. Thank you very much.
Yeah, I love it when a lawyer says as clear and simple as possible. Anyway, so if I can now turn to Tom, if he's hovering somewhere.
Yes, I'm here. So thank you for this nice introduction. A short clarification on all these universities. It looks a bit strange on paper, I think, but it was more a inter-university program, so it's only 1 degree, actually. My apologies, I could not attend in person, but I'm happy to give you a short presentation in this virtual setting on the role of EMA in global cooperation and some initiatives we took on the supply of plasma-derived medicinal products. Yeah, normally you see the presentation now. If we can go to the next slide, please. So a short overview of what I will cover in the next few minutes. So I will share with you some EMA initiatives that we took for the monitoring of the supply of plasma-derived medicinal products. Of course, there's a long history of EMA in the PMF evaluation, inspection coordination, monitoring shortages. But for this presentation, I will focus on some more recent initiatives due to the COVID pandemic. We also sent out some surveys. There was a CHMP position statement published. Then I will give a short overview on some initiatives on inspections we took with the regulatory flexibilities during the COVID period. A short status update on the MRA with the US, and then some information on the EMA extended mandate. Next slide, please. So we sent out 3 surveys end of 2020 and beginning of 2021, and these were really driven by COVID. And the aim was to understand the impact of COVID-19 on authorized medicines where plasma is used for its manufacture. And we also wanted to have a forecast of the inventory for the EU market, assuming the normal demand pattern. All the PMFs holders confirmed they had activated mitigation plans to meet their commitments to patients. And there were some shortages of immunoglobulins notified end of 2020, beginning 2021. But since January 2021, no additional shortage notification was received by EMA. And all PMF holders confirmed they had sufficient inventory for the EU market. And of course, EMA continues to monitor through the SPOC network on any notifications of shortages of the plasma-derived medicinal products. And for that, we work closely with the European Commission and EDQM. Next slide, please. Another initiative was the CHMP position statement on the quality and safety assessment for the plasma master file certification with regards to donor deferral criteria for sexual risk behavior. This was published in February 2021, and in essence, it said that when plasma is collected in accordance with the national recommendations on deferral criteria, that the plasma is accepted by other European countries. Next slide, please. Okay, so here an overview on some regulatory flexibilities on the inspections we took. The COVID-19 pandemic, of course, led, especially in the beginning, to a serious impact on the work of the inspectorates. In the first months, inspections were put on hold almost for 100%, but also in the months thereafter, and even until now, there was a serious impact on inspections. There were, and in some places still are, national and international travel restrictions, and the national competent authorities have initiated business continuity plans that, of course, have impacted their work. Also, the manufacturers may have similar restrictions that prevent them from hosting an inspection team, especially in the beginning of the pandemic. And the GMDP Inspectors Working Group recognized the severity of these circumstances, and they proposed to take some regulatory flexibilities until the end of the COVID-19 pandemic. So what they did, for example, was an automatic extension of the validity dates of GMP certificates. And also last week, during the IWG, an extension until the end of 2023 was being proposed for adoption. There were some flexibilities of import testing requirements, also on QP certification. And then we had some adaptations for some GMP requirements, for example, on process validations, on audits. Next slide, please. And then the inspectors working group also adopted a guideline for undertaking distant assessments. And we saw that the effect of these flexibilities during the past year, that they have been remarkable, and vaccines and therapeutics have been authorized quickly, and the continuity of supply for the vast majority of the plasma-derived medicinal products has been maintained with very few shortages reported. And I added here a link to the Q&A if you want to review it. Next slide, please. And in this Q&A, there is one question on the PMF inspections. And basically, there are two scenarios. So the first one is when you have a site that has never been previously inspected. And for this one, for these centers, we introduced a risk-based inspection planning together with some control measures. And the decision to implement these control measures or to do an inspection lies within the supervisory authority. And these control measures can be, for example, a review of major changes, a review in failures in external QC testing programs, review of other documents like recalls, non-conformances, complaints, etc. But they can also review some information on inspections performed by other authorities, or they can choose to do an on-site inspection of the same team that performs similar operations, and this is in case of a type 3 blood establishment inspection. And after taking or reviewing these control measures, the supervisory authority issues a statement of next inspections to confirm the compliance of that center. And then on the next slide, we have a second scenario. And this is for sites that have not been previously inspected. And if that center is operated by a parent company that already operates other centers that are included in the PMF, then the supervisory authority can perform a distant assessment. And after that distant assessment, they also issue a statement of next inspection. But of course, if the outcome of the distant assessment does not permit the approval of the establishment, a clock stop will be triggered until the on-site inspection is possible. But here it is important, or the terminology is important, and the relevant factor for the new center is whether the parent company and its associated centers is already included in a PMF based on an EU inspection. If this requirement is fulfilled, then the new center can be subjected to a distant assessment and thereby added to a PMF. But if the center is operated by a parent company that has never previously been inspected, or where the parent company is in a compliance management program, then an on-site inspection will be required. And I want to stress out also that these regulatory flexibilities apply for during the COVID periods only. Next slide, please. Here we have a short update on the MRA with the US. For this, the decision to include vaccines for human use and the plasma-derived medicines, this decision was postponed due to COVID-19, and a new date for the decision on a possible expansion of the scope needs to be agreed between the EU and the US. But it looks now that the topic is back on the table, so hopefully we have some good news that will arrive in the next few months. Next slide, please. And then some information on the extended mandate of EMA. So since March 2022, the regulation 2022-123 reinforces the role of EMA in crisis preparedness and management for medicinal products and medical devices. The focus of this regulation is on three aspects. The first one is the monitoring and mitigating shortages of critical medicinal products and management of major events. The second one is reporting medicinal products with the potential to address public health emergencies. And the third one is monitoring and mitigating shortages of critical medical devices in the context of a public health emergency. Next slide, please. Here I won't stick too long to this slide. It's just that definitions of a major event and public health emergency are included in this regulation. Next slide. So as a central part of this legislation, there is the establishment of a medicine shortages steering group as part of the agency, and it is composed by members of the European Commission, EMA, and one representative per member state. And this steering group formalizes the EU Executive Steering Group on shortages caused by major events. The steering group is then supported by a working party of single points of contacts in the member states. This is the current EU SPOC network, and by a subnetwork of contact points from the concerned marketing authorization holders, which is now the iSPOC system. And the regulation emphasizes the preparedness role of EMA, together with member states, to continuously monitor any events which may lead to a major event or a public health emergency, and which may affect the supply, quality, safety, and efficacy of medicinal products. Next slide. Here you see a highly level overview of the composition of the steering group. So in the middle, you see the members of the European Commission, member states, and EMA, with a link to the SPOC network. And we have at the left also some observers of the patients and consumers working party, of the healthcare professionals working party. And the members may be accompanied by experts in specific scientific or technical fields. Next slide, please. And the role and the responsibility of this steering group is first to provide recommendations on measures that the European Commission, member states, marketing authorization holders, and other entities can take to prevent or mitigate actual or potential shortages of medicinal products. Also to coordinate measures taken by the NCA's marketing authorization holders and other entities to prevent or mitigate potential or actual shortages, and to establish a list of critical medicinal products to ensure monitoring of those products. And for example, on this list of the critical medicinal products, last week, first list of critical medicines for COVID-19 was published on our website. Their role is also to evaluate information related to the public health emergency or the major event, and then decide on a need for urgent and coordinated action with regard to the quality, safety, and efficacy of the medicinal products concerned. And they also will provide recommendations to the European Commission and member states on any actions that needs to be taken at union level on the medicines concerned in these legislations. And then as a conclusion on the last slide, so the EMA has undertaken several initiatives to improve and increase the supply of the plasma-derived medicinal products in the EU. So we conducted some surveys. We have exchanges with the European Commission SOHO team and EDQM, and also through the blood cluster meetings with FDA and Health Canada. There was a position statement from CHMP. We had some regulatory flexibilities on inspections during the COVID pandemic. We have a long history of annual meetings with IPPA and PPTA over the last 20 years. There was a small break because of the business continuity plan of EMA, but the meetings have restarted now. And then for the MRA, the work is in progress for implementation of the plasma-derived medicinal products and vaccines for human use in scope of this MRA. And I think that's my last slide. So here, since I cannot stay for the Q&A that will follow now, I included here an email address. If you should have questions, you can send them to that email address and we will respond as soon as possible. And this is the end of my presentation. Thank you for listening.
Right. Given that Tom is going to disappear, why he wants to be anywhere else in the world but here is beyond me. But I'm going to ask a couple of quick questions. The first one, we heard about these regulatory flexibilities related to the pandemic on inspections. So how do we go forward with that? Does that continue, or have things gone back to what they were in 2020, 2019?
Well, on the short term, if we look at the situation now, there are no indications that there will be changes to these regulatory flexibilities. Of course, the pandemic is still ongoing. We luckily see that on-site inspections are being resumed, but the flexibilities will stay in place for now. On the long term, the resumption of the on-site inspections will vary according to the timing of lifting of the different restrictions in all the countries. But the national competent authorities will continue to apply control measures to verify the ongoing compliance of centers previously inspected, as also outlined in the risk-based approach guidance. But at this point in time, the EU national competent authorities are not willing to undertake a decent assessment of a center that is operated by a parent company that has never previously been inspected, or where this parent company is in a compliance management program.
Perfect. One more question in that case. What measures will the EMA take to address the current backlog of third country plasma master file inspections?
Well, as you know, probably EMA coordinates only a fraction of the PMF inspections, so we don't have the full picture of this backlog. But indeed, at the end of last year, beginning of this year, we received a high number of inspection requests that could not be fulfilled due to inspections planning already being full, and also the low number of PMF inspectors and PMF inspectorates. But we decided that we will bring this backlog to the next GMDP Inspectors Working Group in September, and we will ask for more candidates to perform these inspections to address the current backlog, and hopefully these inspectors or these inspectorates will stick for the long future to help the other inspectorates that perform these third country inspections now. But of course, we depend on the national competent authorities for this.
Yeah. Okay. Well, Tom, I hate to lose you, but thank you very much. Go where you need to go.
Okay. Thank you very much.
Thank you. So I'm going to come back now to Peter and ask a couple of questions here. Well, actually, let's start with one major question. How come that we have different national provisions in EU member states regarding collection, testing of blood, plasma? Why is there no simple harmonization of all this?
Well, it's due to the fact we are in the European Union and we do have an internal market, but the Treaty on the Functioning of the European Union provides for a high level of human health protection. And we do have Article 168. I have to mention it because it's an important article. And there it is stated that any member state is allowed to establish higher provisions, a higher standard to quality and safety in the field of organs, blood derivatives, and this might be this is the reason why we do not have the same legal situation in any member state. Mm-hmm. Yeah. Also, it is within the European Union.
Okay. Excellent. So we'll continue that discussion again, but now I'm going to move forward with some new people for you. Firstly, we have Stefan van der Spiegel, who was with us yesterday. Great to have him again here. Trained as a medical doctor, holds an MBA, worked for McKinsey & Co., but he's now head of sector substances of human origin, Directorate General Health at the European Commission. I better run through the others as well. Give me 1 second, sorry. Dr. Jens Rehbein, Plasma Lead, CSL Plasma, Global Regulatory Affairs, Chair of the PPTA Regulatory Affairs Steering Committee, CSL Behring, and Leira Solis, Senior Manager for Health Policy and Advocacy at the International Patient Organization for Primary Immunodeficiencies, better known as IPPC. If I turn back now to Stefan, if we could perhaps pose a couple of questions to you. Thanks for connecting again. We heard yesterday about the revision of the BTC framework. Could you please give us an overview? What's your take on the discussion so far?
Thanks, and thanks again for organizing this very interesting exchange and for having me. Well, I think from the discussions that came so far in the two very interesting presentations, there's 3 points that I maybe wanted to line out to start the panel discussion with. The first one, I think it's clear and important, while it's very unusual for pharmaceuticals, but this type of pharmaceutical plasma derivatives medicinal products, it is important to underline that there is 2 legal frameworks applicable. So one, each has its own function. The substances of human origin framework, with which I mean the blood directive, is really there to make sure in first place that we work with the right starting materials, that we work with the right donors to get those starting materials. And then consequently, the plasma is handed over to another setting where it's being manufactured, and there it falls under the pharmaceutical framework. So that, I think, is a key starting element and a key specificity for the sector. And then, of course, it becomes very important to understand when is this handover from one framework to the other one taking place. And that would be my second point, because we had a very interesting legal analysis of the Octapharm case, and I think it makes clear there that it's important to have the borderline criteria. And the borderline criteria here clearly is the use of an industrial process on the plasma. And those criteria are set within the pharmaceutical framework in Article 2 and Article 3 of the 2001/83 Directive. I just wanted to note with that actually those criteria are not set themselves in the blood or tissue cells legal framework, but the approach we have in the blood tissue cells framework is really to refer to the scope as being set in the pharmaceutical framework. So those Articles 2 and 3. That, of course, and that's my third point I wanted to start with, makes it more important even to make sure there's very good collaboration between authorities of the different sectors. And I think Tom, in his presentation, made some different examples on how we are increasingly working together. And I think COVID really played a role in there in seeing the blood authorities on the one hand and the pharma authorities in the blood products working party and the EMA, for example, come together and have discussions on common views. I think you saw that led to possibilities to have more flexibilities on inspections, also on MSM. So that would be the 3 points I wanted to lay out at the beginning. So the differentiation between the two frameworks, the importance to have a good borderline criteria, and then the importance to have very good collaboration between the authorities of the two sectors.
Okay, good, thank you. Excellent explanation there. So I'd like to now turn to Jens. An opening statement, perhaps, about where we are.
I mean, as outlined yesterday in various sessions and today in basically all talks, there are some indications or some mentioning of a differentiation between plasma for transfusion or blood products for transfusion and plasma for further manufacturing. And even, and I think that wasn't mentioned yet, the EMA guidelines, the guideline on scientific data requirements for the PMF, its annexes, the guideline on epidemiological data, they all indicate and require a separate notification of whole blood and plasmapheresis, as it is called in that framework. And considering that these guidelines are already almost 20 years old. It's hard to imagine that people that drafted these guidelines didn't have source plasma in mind, which is basically the definition for plasma for further manufacturing is what the US Federal Code of Regulations defines as source plasma. So I think the awareness of there being two different kinds, or let's call it types of plasma, has been there for a long time. But what was missing was a clear definition, and overarching definition, not a little bit there, a little bit there, and maybe even a catchy name like source plasma, and thinking it through to the requirements, for a legal framework for the requirements of plasma for further manufacturing, be it donor eligibility, deferral criteria, or other criteria. I think the revision of the blood cells and tissue legal framework gives the opportunity to maybe introduce such a differentiation and open the possibility to maybe an expert body or expert bodies, thinking globally of the FDA, the CDC there, to define specific standards aimed for source plasma, taking into account current manufacturing processes, current scientific knowledge, current testing, and it has to be set up in a way that's flexible enough to react in a timely manner to circumstances that appear. I mean, like the SARS-CoV-2 pandemic, which is a good example. If you had this rigid systems where you cannot change it, and although I'm promoting a clear definition, differentiation, it's actually good that there are some blurry parts in the 2004-33 EC. I mean, there was mentioned these MSM position statement from CHMP. Because it's not mentioned there, the exact wording, MSM, there was some flexibility to define it just as another activity, not a what's it called, high sexual risk activity or something like that. Okay. I see various immediate advantages and possibly some mid and long-term advantages if we manage to set up a clear definition of plasma for further manufacturing and have a line definition globally. But I would start, of course, first, as you have seen, it's the most plasma is collected there, Europe and the US, of course. And it would be a really nice situation if we had a clear definition, a separation from the blood world, and a set of requirements that's flexible and can be adapted on a timely manner. And the SARS-CoV-2 pandemic opened new possibilities, new ways to discuss things, but just as an example, I understand that there was the urgent need to implement requirements and set standards and make sure that the donor or the transfusion recipient population isn't at risk, as well as the plasma-derived medicinal product recipients are not at risk. But it led to kind of a situation, it was, to say the best, blurry. There were European ideas, US ideas, national ideas. There were some source plasma donors had to be deferred for various different amount of time, 2 to 4 weeks, depending on where in Europe you were. Whereas, for example, a national blood transfusion organization in Europe at the same time decided to continue using blood from asymptomatic but positive tested donors. So that it was just a really rough and a chaotic situation we were in. As stated at this event various times already, plasma, and especially source plasma or plasma for further manufacturing, is a global resource. I think it's important that we ramp up the collection of plasma everywhere in the world, maybe outside the US. But even in that case, it would be ideal to have an aligned definition of source plasma or plasma for further manufacturing, that they are which would lead or give way for the possibility to set aligned standards. I mean, there was the mentioning of the recently changed variant CJD exclusion criteria in the US. So they used to be the most strictest, so there was a cumulative time spent of 3 months in the UK, where you had to be excluded in the US as a donor, which was completely stopped recently. It used to be 1 year cumulative time spent in the EU, 6 months in Australia, and as a global company, or as global companies, we were forced to kind of find a harmonization of all these, and it used to be easy because the US were mostly the strictest in most of the requirements, but they changed it quite rapidly due to the pandemic and due to developments societally. The requirements need to consider and continue to consider current scientific development, scientific knowledge, manufacturing processes, and I really think they need to be detached from the transfusion products world, which is usually very locally or regionally, and there are good reasons they are subject to different standards if you think of endemic pathogens, for example, which might not even play a role at all for plasma for fractionation if you think of parasites, for example. Thank you.
Right. Yeah, I mean, donor deferrals and so on. I mean, being a UK citizen, I can never donate plasma in Europe in my life, and I think that needs to be addressed at some point too. But okay, so we've heard now from the legal, the regulatory, and the industry perspective. But now, what we're all here as pharmaceutical representatives is to hear from the patient view. So, Lara, if you can describe to us an opening bid about your perspective.
Thank you, Faraz. I mean, I think the presentations have been very interesting so far, but I think we need to put them in a context, and the context is that we are in a critical situation already now. We've heard from Romania, and we know that in other countries in Europe there are certain limitations in access to the treatments. In Romania, it's really clear. But I want to put it into a more general perspective. What will happen when we will have more diagnoses done in other parts of the world? Not only in Europe, but we know that, for instance, in the case of PID patients, around 70 to 90% of the patients are not fully diagnosed in Latin America, Africa, or Southeast Asia. So what will happen when those patients will be diagnosed, and what would be whether the needs of those patients would be covered with the current status? I doubt it. And I know that we've heard from the representative of the Spanish Medicines Agency that the legislation cannot solve it, but I mean, with the current legislation, for sure, we are not meeting the current demands. So, I mean, at least this is the hope that at least with the new legislation, we will be better equipped to meet the patient's needs. Of course, it will not solve it all, but I mean, at least having clear definitions. We've heard the reasons from an industrial perspective, but I think definitions are also useful as an educational tool. Mm-hmm. And I think perhaps the differentiation between blood, plasma for transfusion and plasma for fractionation is clear to everyone in this room, but it's certainly not clear once you leave this room and this hotel. And I have a very clear example. I know that a patient group decided to run a plasma donation marathon, and they were quite successful until they got the surprise that they got the first phone calls, and they were told that women in that region were not allowed to donate plasma. We were talking about SMSM, but women represent half of the population. And then when men wanted to donate, they were told that the region was self-sufficient in plasma. And in the end, it turns out that they were self-sufficient because they were using the plasma for direct transfusion at hospital. Mm-hmm. And that's why women, in order to avoid any type of adverse reaction in the recipients, were not allowed to donate that plasma. I mean, the patient organization there has been trying to educate the blood bank, the regional authorities for more than a year now. And they still, women are only allowed to donate platelets. So I think better definitions would allow to better educate those that are involved in the whole chain of collection and the development, and also to policymakers to ensure that they understand that they are very different they are very different source products, and they need to be better defined. So that would help with the educational role that sometimes patient organizations need to take on to educate.
Yeah. No, I mean, I absolutely agree with the education and awareness raising is an essential element to how we can bring plasma to people. So let me be very clear about the format here. This is going to be a chat. I have lots of questions here. I don't want to use them. I'd rather we have questions from the floor, if possible, questions between the speakers. So microphones are open, if anyone wants to come. Otherwise, I will ask a question.
I would like to ask first, Antelia. I didn't understand, in a region, it is not allowed to women to donate blood or plasma?
Plasma.
Plasma?
Yes.
And the region is where? In Spain?
Yes.
Okay. And the anti-discrimination doesn't play a role in Spain, or we are within the European Union? How does it work?
Well, apparently the reason it's supposed to be medical, because as the plasma is used for direct transfusion, and a couple of women donated plasma without knowing that they were pregnant, and then they caused adverse reaction in the recipients of that plasma. That's what the patient organization was told. And therefore, there's this ban in that region, but I think it applies also to other regions in Spain, because it's regionalized type of organization.
But it applies to any woman, whether she's pregnant or not?
Yes.
But normally they do know whether they're pregnant or not. but I'm just wondering, because in Germany, really, it won't be possible. I had a legal question from a client. There was I'm not sure whether it was a blood establishment or plasma establishment. There was a transgender, a man with long hair. He dyed them, I think, red somehow. He wore a dress. It was clear that he's a transgender. Mm-hmm. But the reason why he was deferred was that he has not answered to a question correctly. And he was the first one who went to a special place for anti-discrimination. It was first in, I think it was Sachsen or Sachsen-Anhalt. Mm-hmm. And later on, when we answered this complaint of him, it went to the next level, which is the Federal Anti-Discrimination Authority, and it's pending there. Mm-hmm. But in Germany, it won't be and within the European Union, I would say anti-discrimination is the same.
Yes, I mean, I cannot agree more, but that's what, I mean, that's really what the patient organization faced. They were really not expecting that type of reaction and that type of situation, and that's what they encounter, and they've been in discussions for a year now, and this, I mean, I know that the blood bank decided to engage with 2 hematologists so they could facilitate the participation of women in plasma donation, but it's taking some time.
Unbelievable.
It is.
But also here, it would be, I mean, I don't know for what, but in general, a situation like that where you have regional, local requirements for transfusion products, be there a good reason or not, if there's a clear definition or separation for source plasma, which is then further manufactured, where these kind of things might not play a role, it would be easier. And even if the position statement on MSM, I mean, it was said that the member states are now allowed to define their own risk categories and kind of matching it with the categories outlined in what was it, 2004 or 33 EC. But, for example, if then there is an inspectorate from a certain member state going over to the US, they apply probably the national interpretation. And it could be that, that one center, for example, in the United States, would be okay for member state A, but not for member state E, because they have a different national interpretation. Yeah. And maybe it's just a dream, but it might be easier on a European level, at least, to regard or define source plasma as something different as transfusion plasma, and set some more common rules, aligned rules, harmonized rules.
So, Stefan, given you've just heard this, more aligned rules, harmonized rules, how does that sit with the Commission?
Well, thanks. I think that the point came up already at the beginning. Why do member states have sometimes more stringent requirements? And I think Petra already explained that there's that is engrafted in the Treaty of the European Union. That's something we cannot change. So the mandate for the EU is to set common high standards of safety quality, but the member states are allowed and are entitled to have more stringent national requirements. And I think there are some good reasons for that also. I think, first of all, the collection of blood and plasma is very often a part of public health services, and not all the services are organized in the same way in countries. There is not equal means for example, having all testing in place in one country compared to the other, or the types of testing in Germany can be much more stringent, having the NAT technologies, while that may be not available in other countries. So that's one element to take into account. And of course, the second element for differences is the local prevalence of communicable diseases, which can also vary between member states. And that is also exemplified, I think, in the case that was just brought up on MSM, while some member states come to different deferral windows for that. I just want to add to that the reason why the plasma now is aligned to the national rules for blood is because it was driven by COVID, and it was one of the ways to increase also plasma collection. That there was before a standard rule applied that there should be just a permanent deferral of MSM, which I think is highly contested, and which the authorities on blood safety have been for a long time working on, and based on assessments in their local countries, they have come to other conclusion that permanent deferrals are not needed, but more temporary deferrals in function of the factors I just mentioned. So it brings indeed some differences in terms of what's applied in the member state, but it also allows to bring more and collect more volume of plasma and treat that in a way that can be considered of good safety and quality.
Mm-hmm. So this is interesting. MSM, highly contested. UK, still deferred for life. You know, although we're not in the European Union anymore, so you know. Baelen, sorry?
That's incorrect.
We're not deferred for life.
UK are not deferred for life. UK are come to an individual assessment.
Okay. Good to hear. Thank you. Lara, you wanted to say something earlier, didn't you? You look like you did.
I can, if you want.
If you want to.
No, I mean, it was just, I mean, to further elaborate on the need for definition, it will also trigger the discussions about what needs to be in place and so on, because you can, I mean, the frequencies and the quantities of donation are not the same, so that would trigger. But also from an employer perspective, if you're in a country that gives blood donors a day off, and if you were to be a donor, I mean a plasma donor, like the one that we had yesterday that was donating every other week, would you allow your employee to take 24 days off aside from his normal holidays? I mean, I think this type of discussion, I mean, by laying out the fundamentals of what the differences are, you would allow a further reflection on what is needed to the bigger picture that needs to be reflected upon in terms of, well, if you are looking into financial neutrality, how you achieve that, what it's the whole system that needs to be accompanied. But of course, depending on which member state you are in, you would not, we would not ask for a general setting for all, but really for member state to individually think about it in order to for all of them to collect more plasma.
Yeah, okay. So microphones are still open. I see no one standing there. Well, I'm going to have to ask my own questions then. Ah, wonderful.
Forgive me, but I mean, you are encouraging questions.
I'm trying.
I've got one for you. It seems to me that when I was in the NHS and working with doctors and nurses and managers, one of the questions I used to ask was, if we were having this conversation at a patient's bedside, would the patient understand why it was relevant to them? And what's occurring to me in this conversation is the extent to which the fine points, and these are all very interesting and important points, but the fine points of detail around much of this agenda are not actually relevant to the core issue, which is how free are we right now under current rules and regulations to get on with the job of collecting a lot more plasma. So my question to all of the panel, and I hope also to colleagues here, is what could we do right now if the rules didn't change and there was no harmonization and the poor old bureaucrats got on with whatever it is they do in their lofty towers of paper while we get on with the job? What could we do immediately without any changes?
Bureaucrats, lofty towers of paper. Stefan, surely.
I thought the question was first addressed to you, for who is doing the action in the field. So maybe you can answer first. I'm happy to compliment on that.
Oh, no. I'm giving the floor to you, the experts, not to me. So anyone? Leo?
I mean, from a patient perspective, I mean, we've heard of many initiatives from our national patient organizations, for instance, that we have a wonderful one in Spain where they got together around the table, scientific society, other patient groups depending on plasma-derived medicinal products, blood banks, some of the blood donors, and they drafted a consensus document highlighting all the hurdles that they were encountering in the Spanish system, of course, and providing some suggestions on how to overcome them. And I think this document will be used to educate. And I know that from first meetings that they had with blood bank managers from some of the regions, it was really well perceived. So that's one of the things that we are currently doing as patient organizations to ensure that, I mean, if things do not change, we are triggering the change by engaging in discussion and dragging people from different fields together to make sure that policymakers do understand the needs, the current needs, and what needs to be changed from our perspective. So that's how we can contribute, at least to the discussions.
But is that a regional thing in Spain? Is it a national thing?
That would be a national thing. I mean, because that was one of the problems that was perceived, that different regions were looking at it differently. So we are trying to, I mean, the consensus document tries to bring up the level and try to suggest the best practice to all regions.
Okay. Jens, Peter, anyone want to come in on this?
I mean, the question I think frankly there's nobody in the room that can really have a really tangible what can we do in the current framework. I think it's exciting times because we are about to see a new BTC legislative framework come up, and it's exciting, and there had been in the last maybe 20 years of frustration about it because it's not that we didn't try the best, but it has been rigid or defined pretty much the same way it is nowadays for the last 20 years, and that's why it's so exciting and so important that we send the ship in the right direction with the new BTC legislation, because we tried our best in the current one, which has been implemented or has been valid for the last 20 years. And I've commented on the blood and tissue, or the blood directive basically previously, various times, because and there was like the Brexit, and then it was postponed, and then it was COVID. So I throughout the years, I 2 or 3 times I started, commenting on that, but then the revision was postponed again and postponed again. So we already have been working in the framework for, as I said, around 20 years, and there's the possibility to change it, and there's more awareness maybe to the pandemic, and there has been a tremendous evolution in manufacturing, testing, knowledge about viruses. So and we can throw everything into it and need to make sure that the ship sets off in the right direction.
Peter, Germany, maybe?
Well, I have another point of view. I've learned since yesterday that the plasma situation in the USA is much better than in the European Union, and that I've understood that we do import plasma, US plasma, to the European Union. But I'm really wondering, Tom mentioned the mutual recognition agreement between USA and the European Union, and still blood and blood derivatives are not mentioned in the mutual recognition agreement. I think he said in some months it may be included. And I'm really wondering, I know we do have participants here from the USA, I'm really wondering, we did have a draft from 1999 between USA and the European Union, which was never in force. And it took us about, I think, 20 years to have a mutual recognition agreement between the European Union and the USA. And still today, blood products are not included. And at the same time, we say that the USA has the more stringent regime than in the European Union.
Used to have, yeah.
Used to have.
But it's not only that they are not included, they are specifically excluded.
Yeah.
And I think that's, I don't see it tomorrow, but that's one of the opportunities I see mid-long term. I mean, if you start regarding source plasma as a biological raw material, other than the dirty brother of the transfusion product, and regard it as a highly valuable pharmaceutical raw material, it might be able to even direct it under a different legislation and easier include it into mutual recognition agreements.
So, Stefan, I see you're writing a lot, so there's a lot of paperwork there. So
Exactly.
Please, come back, comment.
No, thanks. Very interesting points to say. I think on the imports, yes, of course, we need to make sure import can continue in a fluent way. But I think the whole direction or point of attention that is being put on the table is really to make sure that there's more collection within the European Union. And I think COVID has also made clear why we need more of our own collection in the EU. And that's not only for plasma as a starting material for this therapy, that's also for starting materials of many other therapies. So on that increasing plasma collection in the EU, I think there's 3 elements to take account of, and the legislation is only one of them, and that's also why I want to manage your expectation a little bit. Of course, yes, we will try to streamline the legal framework. We'll try to make better interactions with also the pharma framework. We will bring in some provisions that will help, but there, in the end, the collection is really organized by services, public or private, in the member states. And the 2 things you really need to happen is as our Spanish member in the panel mentioned, very good organizational flexibility in those services, whether they are public or private, to make sure they can collect as much plasma as possible. And B, of course, is the full awareness within the population and the willingness within the population to make donations. So I think even we might tomorrow get the best possible legal framework. If those two other elements are not in place, we will not get more plasma. It is really about getting the population's willingness and awareness, and about getting the organizations in place.
Excellent. I think we have a question from the floor. Brian.
I want to throw out a couple of general comments and get the panel to react to that. I think, look, there seems to be a clear recognition that both the public and private sectors need to collect more plasma in Europe. On the other hand, we also hear about self-sufficiency. And part of the self-sufficiency argument that I'm hearing says, well, maybe there's too much use. Maybe there's too much immunoglobulin being used. Maybe patients are being overtreated. Maybe there are too many indications. And to me, there seems to be a false definition of self-sufficiency in some people's minds, where it means the amount of treatment we can provide from the amount of plasma we can manage to collect. So rather than making strenuous efforts to actually increase plasma collection, they're saying let's have better treatment protocols where we restrict use. Now, I'm in the haemophilia area, and 30 years ago, in 1992, we had a white paper on rational use of factor VIII, and the conclusion was rational use was 1.9 IU per capita. Now many countries are using about 10 IU per capita. The reason we're able to do that is because we've decoupled haemophilia from PDMPs, so we have recombinant alternatives, we have subcutaneous alternatives. But I am absolutely sure that if we were still reliant totally on PDMPs, as indeed the PID community are, that from back of the envelope calculations this morning, for a 70-kilogram man with factor VIII deficiency on standard prophylaxis, you would need 1,820 plasma donations per year. We would be told at this point, oh no, you can't use 10 IU per capita, you can't use 5. We have to rationalize use because that's self-sufficiency. So I think what we're seeing from a patient perspective is a strong sense of frustration because we keep being told that there's overuse, while in fact the real problem is we're not collecting enough plasma. Europe is not pulling its weight.
Okay, so there are a lot of hungry people here. So I'd like some reactions, but quick reactions, please.
Ladies first.
Ladies first. You can just say yes.
As far as I understood, I fully agree with you. I think the plasma collection should increase, and I really think we should do more advertisement for the plasma collection. Myself, I was not aware of the fact that we do have advertisement for blood collection, but not for plasma collection. And I'm not sure whether, say, people outside this room know the difference between blood and plasma. And I remember we do have in Germany, for example, a blood donation day. But do we have a plasma donation day?
No, we couple them together.
Oh.
So we try to, in essence, piggyback on blood donation day. But yeah, you make a good point.
I'm not a marketing expert, but I think advertisement for more plasma collection could be a good way.
Yeah. Yeah?
I think I can only concur with what Brian has said. I mean, Europe needs to collect more plasma. All countries need to collect more because right now we know that we are not, patients' needs are not met. And if we start diagnosing more, we cannot say, we cannot be told that you don't have the product, because then what's the point of diagnosis, and are we leaving those patients with no treatment? I mean, that would be the main question. We need to think about each region collecting more. We are in a global scale. The national scale doesn't work any longer. And just to underline that we need to do more for those that are currently not diagnosed.
Okay. Jens?
I think we already heard very nice, especially from the patient's perspective, closing statements. I don't want to water them down. I think the message was clear. I think it's...
So, Stefan, one last statement, perhaps?
No, I fully concur with Brian's statement. I think we need we need more collection in the EU, but in the end it will be, it's a chain from donation till application, and I think there's many actors in between a donor and a patient at the end of the chain, and there's a task for all of them, whether they're public or private, whether they're at the beginning, the collection stage, or more at the manufacturing, the further marketing stage. I think there are steps for different steps, and there's to-dos for all of them, because one alone will not solve this.
True. So before you start eating each other, I'm going to close this panel and say thank you very much to all the speakers. Marvelous discussion, and I hope you agree with me, this has been the best panel. Thank you very much.
Bye.
Good afternoon, everyone. Whilst you are trying to find your seating arrangements, welcome to the final and probably the most interesting session of the IPPC. I know my predecessor said that his was the best session. This will be the best session. So my name is Domenica Mistella. I'm PPTA Senior Director for Regulatory Policy Europe, and it is my pleasure to welcome you to final best session of the IPPC. Together with 4 esteemed experts, I will be discussing improving pathogen safety, key highlights and developments for this industry. So pathogen safety has been at the forefront of this industry for decades. We know precisely why, and we shall not forget our history, and this is a very, very important aspect. Together with regulators, this industry has worked for decades to make sure that the products that our patients receive are safe. And the 4 experts that will talk about how safety is maintained with regard, for instance, to SARS-CoV virus, COVID pandemic, with regard to the newly emerging now or emerging monkeypox and other issues. We will also discuss, for instance, how certain regulations have changed based on data generated by pathogen safety experts. So please welcome. The first speaker is Ruth Offergeld from Arbeitskreis Blut. She is the chairperson of the Arbeitskreis Blut. The second person, very, very my pleasure, chairman of the PPTA Global Pathogen Safety Committee, Thomas Kreil, vice president Global Pathogen Safety. Eleonora Widmer, she also works with me on the Global Pathogen Safety Committee of PPTA, executive director Global Pathogen Safety. And finally, David McIntosh, the chairperson of UK Plasma Action. With this, a few words about Ruth Offergeld, who will come to speak first. So she is a transfusion medicine specialist and also an epidemiologist. After her clinical training, she joined the Robert Koch Institute, and this is actually the German National Public Health Institute, where she's responsible for infectious disease surveillance in blood and plasma donors. And she's very well known and very highly regarded in our industry. She has conducted multiple studies on residual risk estimates, donor selection, and compliance for the safety of blood products and supply. Since 2014, she's the chair of the German National Advisory Board for Blood Transfusion. Dr. Offergeld, with this, may I ask you to come to the podium?
Yes, thanks a lot. I'd like to thank you organizers and you for the kind introduction, for being part of this best session of the Congress. I'm very pleased to give you some insights about the mission and the role of the National Advisory Board, which is similar to other boards that you are probably well aware of, like the BPAC or the SAPTO meeting. This is what we have in Germany. So the National Advisory Board looks back on a long history. Actually, it was founded in 1993 when, unfortunately, a few more HIV transmissions occurred, and the Ministry of Health at the time decided that apart from all the regulations made by the competent authority, it would need a scientific board to give them advice on certain aspects of blood and plasma collection, transfusion, and all related issues. So at that time, the Arbeitskreis Blut, the National Advisory Board, was founded. And its main mission is to give advice to the federal and state authorities, and it is also now laid down in the Transfusion Act. And it consists of quite a large group of experts, and they come from various areas. They're experts for transfusion medicine and also from related clinical fields who do the transfusions. And we have a couple of patient representatives in our committee, and this is probably unusual. We also have industry representatives, and they do have voting rights. So conflicts of interest are evident here, and actually PPTA also is a member and has voting right, and Dr. Giles is the current member of our committee. And also, as health issues are the responsibility of the federal Länder in Germany, representatives of these are also members of the advisory board. And the board is appointed by our Ministry of Health every 3 years, and we currently have 33 members, so quite a large group. We meet whenever needed, which is usually 2 to 4 times a year. And in the beginning, Professor Burger, who was then the vice president, later the president of the German CDC, was the chair of the committee until 2014 when I took over. Now, what do we actually deal with? The main issue, and this is why I'm in this session, is naturally the risk for transfusion-transmitted infections. And now that we've the classical infections with HIV, HCV, HBV well under control, emerging infections become more important. And with West Nile virus, Zika virus, SARS-CoV-2, and now monkeypox, we have not been bored recently. The other main issue that we are dealing with, and this has been also quite an issue in this conference from what I heard today. Unfortunately, I wasn't able to attend yesterday, but I heard that it was also very important here is the supply issues. So how can we guarantee, even in the future, the availability of blood products and plasma derivatives? And how do we deal with this in our committee? We talk about screening tests, whether they are necessary, whether we need additional tests. We talk about donor selection, surveillance, hemovigilance, and also uni and post on-the-job training for transfusing and giving plasma derivatives. What means do we have to actually give our advice apart from writing reports to the Ministry of Health? We issue votes and also expert opinions, and we are heard whenever new legal regulation is about to come. And as of May this year, we've issued altogether 70 votes and 63 expert opinions, and a bit more than half dealt with specific pathogens. I want to give you a few examples of these votes that we have issued, and one that has been very well recognized and very much appreciated by many is the one on look-back procedures, which was last updated in 2020, and we have laid down the tracebacks in flow diagrams and in a very detailed manner, so you can really work your way through a look-back procedure here. And with respect also to TTIs as well as supply, we also recommended the use of a uniform donor questionnaire in Germany. It is recommended, it is not mandatory to date, and we did that as early as 2010. And if in preparing for this presentation, I realized that beforehand, we already dealt with possible challenges in a pandemic in 2009 when we had a vote called blood supply in case of an influenza pandemic. That was actually the virus that we feared most at the time. I just want to give you one example that is a bit outdated but still demonstrates how important these votes are. We actually voted for the introduction of HCV NAT as early as 1998, and it became mandatory a year later. Now, people might ask, well, this is an advisory board, what does it mean if you issue a vote on whatever? They are not legally binding, but they're considered as anticipated expert opinions, and being sometimes involved in court cases, I can assure you that you have to have very good reasons not to go along with the votes of the advisory board. Now, the expert opinions usually, or most of them, deal with specific pathogens. The last one we wrote was an update on malaria just at the end of last year. And of course, SARS-CoV-2 you will find something on that as well. Zika and Borna disease virus, and a virus that is endemic in Germany, Austria, and Switzerland. Those were all important to us, and we had to see whether these would pose a risk for transfusion or for plasma derivatives. But we also have expert opinions on other issues that are pressing, and one that really kept us busy was the question of transfusion-associated immunomodulation, so-called TRIM. In the course of the implementation of patient blood management, some people argued that transfusion of blood components actually caused harm and led to more septicemias or even malignancies in recipients. And there was an abundance of publications which we sort of sorted out and put it all down in our expert opinion. And also other issues that are of high interest, for instance, the transfusion of the incorrect blood component, which is a far greater risk these days than transfusion-transmitted infection. And also, because it has just been so relevant in the past 2 years, we actually did issue an expert opinion on convalescent plasma already in 2015, when we said, well, we need to evaluate the use and the feasibility of collecting convalescent plasma at the time. And as you can imagine, this really speeded up when Corona came around the corner. So what are the topics that we are dealing with now? What is the most pressing issue? And one is that has just been addressed in the past session was donor selection and sexual risk behavior. You're probably all aware of the intense discussion about this population-based deferral for sexual risks that has been ongoing for years, and it was perceived as discriminatory and also as not working properly. Actually, the advisory board started discussing this issue in 2008 when we saw an increase in HIV infections in donors despite the permanent deferral being in place. So we said, well, this is probably not really working and we need to take a closer look at it. And then we had the permanent deferral in place until 2017, when it was reduced to a 12-month deferral, which in fact is still a permanent deferral. And then we formed a joint working group which intended to include all stakeholders here, the competent authority, the Ministry of Health, the National Public Health Institute, the Chamber of Physicians, who's responsible for issuing the chemotherapy guidelines, where all donor eligibility criteria are laid down, and the advisory board. And we over the course of, I think, 8 months or something, we compiled all the current scientific knowledge, especially the epidemiology and hemovigilance data and international experiences, and we recommended a change. And how does that look like now in Germany? We first of all reduced, or recommended to reduce the deferral period from 12 to 4 months. And we also made a new definition for high sexual risk behavior. And we said in this recommendation that we believe that this is the case if you have a frequent change of partners in heterosexuals or trans persons. And for MSM, we said more than one partner or a new partner within the past 4 months. All these criteria refer to the past 4 months. So having performed sex work or being a client of a sex worker in the past 4 months is regarded as higher risk behavior, as well as sex with someone who is infected with a transfusion-relevant infection, and also if you had sex with someone in or from an endemic area. The National Advisory Board approved this recommendation, but added that it was necessary to scientifically evaluate these changes and see what effects it might have on compliance, as well as on supply and donor eligibility in general. And last year in September, the binding chemotherapy guidelines were updated, and this came into effect. Another issue that I'd like to briefly talk about, and which has been of great interest here as well, is supply issues. The pandemic revealed that the already difficult situations in summer months or in certain areas with the collection of blood and plasma really was an issue and posed challenges for the blood establishments. And in this graph, I've sort of tried to show that these are all interacting areas. You have the plasma or blood establishment, and you have personnel issues here. It's difficult to get to recruit the adequate personnel. You have, on the other hand, the candidate donors that you have to select, and there are certain things that impact on the willingness to donate and the eligibility. And a great point is the societal recognition of blood and plasma donation. I think this has been discussed here in this at this Congress as well. And on the other hand, you have the perceived old-fashioned discriminatory attitude of blood establishments, especially with all the regulation that I just talked about, referring to sexual risks. And also the commercialization is something that worries candidate donors, especially young donors, saying, well, they want my blood, my plasma, and then they make a lot of money with it, and therefore I'm not going there. So it's not simply a question of willingness or availability of centers, it's also something that we have to address in a broader way. And we can look across the border and see what other states are doing in this, and we have to look at regulations, and we have to really try to get a comprehensive approach to this. And the advisory board actually tried to address this, and we decided to, in various subgroups, to address all the various topics that I just briefly touched. And probably for this audience, it is relevant that in the group plasma collection, for instance, we're talking about is the physician at the donation site, which is a German peculiarity, is it still needed? What about plasma volume, donation frequency, with respect to donor safety? Is data strong enough to advocate more frequent donations or higher volumes or in individualized plasma donation? Things like this will be a topic in this subgroup. And with respect to donor recruitment and retention, we talk about remuneration and non-monetary incentives. What is the best way to go along? I just said this. There are also other issues that keep people from donating, and we will have to address these as well. So this is a huge task. I cannot present any results because we already started at the beginning of this year. This is work in progress, but this is what the advisory board will address in the upcoming months. So with this, I'd like to close, and I hope I could show you that we have been quite successful in giving advice to the relevant authorities in the past 3 decades, and we also are always striving to address things in a timely manner, and the expert opinion on monkeypox is already on the way. And we include all relevant stakeholders. We're not limited to the members. We can also include others if we feel there's a need as guests on certain topics. And the votes and expert opinions are not legally binding, but they do have a great influence, at least in Germany. And, well, yeah, emerging infections, sexual risk behavior, and supply issues are the topics that we are working on right now. So with this, I'd like to thank, and I'm happy. I think questions will be at the end.
Yes, I forgot
I'm
to
happy
say,
to take any questions at the end of the session. Thank you.
Thank you very much, Dr. Offageld. Yes, please keep any questions for later. With this, I would like to invite the next speaker, Thomas Keil. He's very well known in our circles to those who are not familiar with him. Thomas is the Associate Professor of Virology and Vice President of Global Pathogen Safety at Takeda. And beyond being chairman to our very esteemed committee, he's also a steering committee member of the Consortium on Adventitious Agents Contamination Biomanufacturing, and also an associate professor at the Institute of Virology at the Medical University in Vienna. So Dr. Keil is actually a biochemist by training, but he has, in the meantime, specialized in viruses for some years. And yes, Dr. Giles, it is my pleasure to welcome you and tell us a little bit what the future holds for us in terms of new and emerging and exciting pathogens and what we can do about them. Thank you.
Well, thank you, Domenico. Thank you for a really nice introduction. That's always my problem. I should have a crystal ball as a tool that I don't have. No, I will say that I'm actually quite pleased to see a nicely filled auditorium at the very back end of a conference. That tells me that viruses, and particularly emerging viruses, are not an issue of the past. While we have come a very long way of safeguarding plasma derivatives and therefore have not seen transmissions for decades, there is always this new challenge every time a new agent comes up. And what I would like to review with you today is some of the principles that we have put in place that have gotten us to a better place that we are in right now. So emerging viruses in the context of really two different questions. The one is the safety of the products against the transmission of viruses. But with immunoglobulins being the major drivers for plasma fractionation these days, I think it's equally important to understand what the efficacy of these products against the emerging viruses looks like. So I'm going to start in the past because I don't have that crystal ball. The past is easier. We live in this volatile environment, and some 2 decades ago, we had an experience with a new virus at the time. It was actually not new, but it was new in the geography that we observed it in. So it came out of Africa into the east coast of New York. And that actually did change a few things. Just to illustrate, it's a virus that is mosquito transmitted. West Nile, that's because it was first described there. It really causes fever in only 20% of people, and the rest are completely asymptomatic while infected. And only in maybe 1 in 150 or 1 in 200 cases you see neurological sequelae. But in 1999, it happened, so the virus occurred in New York, and ever since has established endemicity in the United States, with some 25,000 cases of neuroinvasive disease. That's a large number. And if you think about it, 1 in 200 that is, so it's millions of people in the US that have been infected with West Nile virus. So the learning from that was, as you can read at the bottom, pathogens can indeed move among the population centers of the world. And that was 2 decades ago. 2 years ago, we have the same thing happen over again. And I think it would be an illusion to think that this has been the last. So in terms of the safety margins of plasma derivatives, we did have a couple of really good learnings from that one as well. So the safety tripod concept, the selection of healthy donors, the testing of donations, and then the manufacturing process with its virus inactivation and removal procedures, well, quantitatively, very different contributions. The selection, if only 20% run a mild course of fever, that means you won't detect the other 80%. So a minuscule reduction of risk by selecting donors. Even by implementation of NAT testing, and no, Jan, I'm not going to say PCR, the risk reduction is actually quite modest. It is only half or maybe 2/3 of the viremic donations that were identified. The others were actually too low, so that the total risk reduction was 93%, or to put that in a log scale, 1 log risk reduction. Now compare that to several orders of risk reduction in every manufacturing step designed to do that. So we have many log steps in the manufacturing process. And the consequence we have also seen in that blood products, where the agency at the time mandated the use of NAT testing, the most sensitive test technology available, we still saw, despite more than 1,000 presumably viremic units being discarded and not used, we have seen a few blood transfusion transmissions, because a non-reactive assay does not mean negative, and below the limit of detection can be still enough to transmit. So, but that's what happened in the blood world. There was at the time no requirement made to implement NAT for the testing of plasma for fractionation, based on the demonstrated virus reduction capacity of the manufacturing process, and therefore, plasma derivatives did not transmit the virus. So it's important to differentiate, therefore, these two different uses of products that actually come from the same vein. But we have actually learned something else too, and that is, in the beginning, the very left of this chart, there were very few cases of West Nile virus in the United States. You can see the cumulative incidence of infections in the black lines here. It was only around 2002 when the epidemic really took off. And based on an increasing number of people having gone through West Nile infection, and therefore now carrying neutralizing antibodies in their plasma, that we also saw the orange line take off, and that is the neutralizing capacity in immunoglobulin preparations. So it's nicely parallel, as you would expect. More people with antibodies, it translates into better potency of these antibodies in IGs. Now the question you might ask, is it relevant? Does it matter? So here we have tested immunoglobulin preparations for their efficacy of protecting against the virus infection in a mostly lethal mouse model. So the one black line there at the very bottom is, over time, if you infect these mice, they die from West Nile virus infection. If you treat them with the black line, the other black line, IG prepared from European plasma that at the time did not contain any antibodies to West Nile virus, that didn't make a difference. But the orange line now, those are immunoglobulin lots that were prepared from US American plasma. And they did carry the neutralizing antibodies, and therefore, even in that extreme model of infection, we're able to provide full protection. So there's two things: does it transmit, and can it protect against? And both of these, I think, need to take a hard look. Summarizing this here, verification studies is a term we have used over time to confirm the assumptions about manufacturing processes' capability to deal with minimal virus loads. But I think viral verification does not only cover the question, is transmission possible, but it also covers the question, is immunoglobulin prepared from that plasma then protective against that virus infection? I think it is important also to stress that we have learned that blood for transfusion and plasma for fractionation is very different. And that's what we've learned in the session before lunch. And I think this is just another testimony to the fact, despite the testing, we have seen transmissions by blood which did never occur from the fractionated plasma. So I think it is important to stress that while both of the products come from the same vein, they do need a differentiated regulatory framework so that safety measures here don't get into the way of collection there. This is a concept that we were able, quote unquote, I would say, to verify times and over again. I mentioned West Nile virus first occurred 2 decades ago. Then we had the bird flu, we had chikungunya, hepatitis E virus, more limited to Europe, and Zika virus. And we have done the same thing over for all of these concerns. To eliminate the concerns, to provide for some peace of mind for patient organizations and regulators, frankly, alike, we have done the investigations to show that manufacturing processes comfortably can deal with these minimal residual virus amounts that might be present in plasma. Now, obviously, the one thing that is still on everybody's mind, SARS coronavirus 2. So how did it work there? When it came up, it was realized the virus is first lipid envelope, which makes it sensitive to inactivation. It is quite large, which makes it sensitive to removal. And the first report out of Wuhan reached the World Health Organization on January 5, 2020. Just 3 weeks later, my colleagues in the Pathogen Safety Steering Committee under Dominica's leadership published to the PPTA website an assessment summarizing all of these facts to say this is not a concern for the safety margins of plasma derivatives. Now, this industry now has grown beyond plasma. The same concepts are applied to recombinant proteins now. So that was also verified. What you see on the left block here, that is an investigation to look for the cell lines that we use to produce recombinant factors, for example, that they were not infectable even by the SARS coronavirus 2. So that's good news. The block with 2 indicated here, this is the adventitious virus testing panel that is in place to safeguard these processes. And it was confirmed that, yes, they would detect the presence of the virus if it were there. And then the third one, that's actually similar to plasma. In the downstream, there is an activation and removal of these viruses, and it would have comfortably taken care of any minimal virus load if it had been there. So not a problem in the terms of safety. That was verified. So how about the second question about the efficacy? I'm just summarizing here that we have seen no SARS-CoV-2 neutralization in IGs collected from plasma pre-pandemic. Then with the first cases of post-COVID plasma donors, we saw that there was a rise of that neutralizing potency. And then finally, with the rollout of the large and really effective vaccination campaigns, we've seen a very dramatic increase. And I think what I would like to illustrate is, initially, the virus had the upper hand because the antibodies didn't cover it. That has changed. And Eleonora is going to walk us through a lot of the details of the investigations that have been done in that subject, but it's important to summarize that, I think. I'll take the liberty to also illustrate how complicated it is, because we have had coronavirus in circulation in humans before we had SARS coronavirus 2. So initially the question was, would there be cross-neutralization maybe through the antibodies against seasonal viruses? And as you can see here, the seasonal coronaviruses are quite potently neutralized. SARS-CoV-2 in the beginning was not. That has now changed for SARS-CoV-2, but it's important to stress that this has not changed the neutralization potency against the seasonal viruses. And even those can be a concern for people under treatment because there's breakthrough infections, but there is no enhanced cross-neutralization after the pandemic. So how about the future then? As I said, I don't have the crystal ball, but what I can assure you of is that the Pathogen Safety Steering Committee in PPTA monitors the environment all the time for information about potentially emerging new viruses. Yes, there is a newly found Ruby virus in Germany, of all countries, superb surveillance, and still it was only now detected. Monkeypox, it was mentioned. We see right now, I think, the beginning of an episode. It was mentioned earlier that we have by now some 3,000 cases, so we do know that it has been in circulation in this community for a while. And next Thursday, the WHO will decide whether this is a public health concern of international dimension, which would allow them to take more effective measures to break transmission chains. We have seen an adenovirus that potentially is associated with hepatitis in really young children, some 10% of them needing a liver transplant to survive. So none of that is comfortable, I have to say. We have seen parvovirus emergence. This is over the last 5 years. A new parvovirus in rodents and bats in South America. In horses, that was actually transmitted through a horse-derived plasma derivative. In cattle, we have seen in febrile humans in South America a new parvovirus detected. I mean, we need to acknowledge that the microbiological environment that we live in is volatile. But I think equally we need to acknowledge that the measures we have put in place over the decades have been really robust. They have proven, they have stood the test of time. And we're not going to miss a beat to monitor what is coming up there so that we have good answers for people raising questions. So in summary, I will say verification, yes, for the safety margins to make sure that there is not a possibility for virus transmission. But with IgGs now a dominantly important plasma product, I think it's also important to keep an eye out for verification of the efficacy of IgGs against virus infection. For all of that, excellence in virology is needed. I'm the first to be really proud that I am a virologist, and we have quite some capabilities. That doesn't apply to Takeda only, it applies to all the member companies of the PPTA. This is where my family at times says I live. That's our BSL-3 lab. I will make mention there's 3 waterfalls sprayed on the left of the building to illustrate the Takeda value principles. PTRB, that's how we take our decisions. Patient, is it the right thing for the patient? Then trust, reputation, and yes, business. With that, I would like to close. I'll sit down and hope that there may be questions, please, ones that I can answer. Thank you.
Thank you very much, Thomas. I sometimes wonder how you sleep at night knowing about all of these viruses that can emerge, re-emerge. Anyhow, I would like to ask the next speaker to come forward and actually talk to us a little bit about what it means once protective antibodies are present in immunoglobulin preparations. And this is quite important considering we now are collecting plasma from a population that has been either vaccinated or has had COVID. So Dr. Widmer is going to walk us through this and whether this is actually protective, could be protective for the patients who rely on those. About Dr. Widmer, she's head of global pathogen safety at CSL, and she focuses specifically on plasma-derived products. She holds an MD from the University of Bern and a PhD in molecular immunology from the University of Lausanne. Prior to this, she has worked at the Federal Office of Public Health in Switzerland, and since 15 years, she is the pathogen safety expert at CSL. And I'm very delighted to work with Eleonora on the Pathogen Safety Committee. Eleonora, Dr. Widmer, please come forward. Thank you.
Thank you. Good. So Dominica certainly has whet the appetite for what I'm going to present, and I hope to be able to answer a lot of your questions. I know already that I won't be able to answer all of them, so spoiler alert. What I'd like to talk to you about, and my slides are moving. there we go, is two aspects. And the first one I think I can touch upon very briefly because it was in part already covered by Thomas in his talk, which is to just reaffirm that our products are safe in the face of this new pathogen that we've all had to encounter. And the second part of my talk is how this changing pandemic has impacted plasma and ultimately the products that we're making out of them, and any implications that we can at this time derive from this data. So to the safety, Thomas already mentioned very, very quickly there were reactions, and everybody was aligned in the conclusion, plasma-derived products are safe. What I wanted to stress here as well is the speed. Thomas mentioned we were one of the first to take position, and it really gave us, as well as obviously everybody who depends on these products, confidence. At CSL, we have taken the exact same factors into account that Thomas already mentioned. I don't think I have to go into detail in these. Obviously, SARS relatively quickly was shown to not have high titers or even infectious virus in plasma. There were no transmission cases reported with even blood products, and as Thomas already explained, there is a difference. We do have all the reduction steps in there, and that's what the last point speaks to. We know that the existing reduction measures are effective against this virus, and where necessary, we have supplemented that knowledge with additional studies. So the product safety from the start remained assured, and we have full confidence. This is to show you how we go about this on a high level. Obviously, speed is of essence. Whenever something comes to our attention, we need answers fast based on any information that is out there and that we can rely upon. It has to be comprehensive. Typically, it starts off with paper-based risk assessments. And as soon as we had the virus in our laboratories, all of us, Thomas mentioned his laboratory, we worked in generating additional data that could offer us any additional insights, and so have we. And we do strive as manufacturers to not only make that data available to us, to back our conclusions, but to actually also make that information publicly available. And in addition to the plasma-derived products, I just wanted to mention this. I know this is not the remit of this group necessarily, but of course we have also looked at any potential impact on recombinant products, on our vaccines, and so on. And we pull together whoever we have to, any internal experts, any external groups that we can collaborate with. And it has, again, highlighted the importance of surveillance, of being ready, and we need to continue to be vigilant. Now, the changing pandemic and what we know about plasma and our products. There are multiple elements in this, and two of the most important ones, obviously, are the donor and the patient who receives the product. And on both sides there are factors, and I know this list isn't comprehensive either, but on the donor side, obviously one of the most important elements is what are the SARS variants that the donors have encountered that they may have produced antibodies against? Have they been vaccinated? With which regime potentially even? Especially early on that mattered when we weren't all fully vaccinated yet. What immune response are they able to mount against either the virus or the vaccine? What's the half-life of these antibodies with regard to the donations that we then collect to make product from? On the patient side, similarly, obviously the variants can be different that the donor has encountered versus what the patient ultimately encounters. Geography differences, but also timelines. The composition of the antibody that are contained in the product. Antibody half-life again, which is also impacted by the patient themselves who are receiving this. And then any variant cross-reactivity, and what I mean here is especially in regard to, for example, we may have seen SARS BA1 in the donor. The patient may be encountering BA5. To what extent is there cross-reactivity? We don't know, and at the time that we collect the plasma, we certainly don't know what the patient will be encountering by the time they get our product. And that's what you also see in the middle, and it was mentioned earlier today already, there is a substantial offset between the time of collection and the time that the product makes it actually to the patient. And this will be important also for some of the pieces of data that I can show you later. And this is again to the timeline. This is a high-level one, and bear with me. So we all know with the virus, there's been variants, and we are now on Omicron, and I suspect that we at least don't know what's next. And the same goes for donors. You know, when we started collecting plasma that could be relevant to these questions, the first donors were the convalescent ones, the ones that had had early infections. Then vaccination started to roll out, and both convalescent and vaccinated, or both, donors could come to our centers. And on top of it, now we're at a time when boosters are being rolled out as well. So we have this whole range of potential donors that contribute to product. In the case of the product, this is to show you what the basis was for the data that you're going to be seeing on the next slides. Initially, the very first thing that, after assessing the safety, obviously, we did as a plasma industry was to pull together and see whether we could do something therapeutic, whether there was a hyperimmune that we could manufacture. And many of you are aware of the plasma lines that we formed, the hyperimmune that we manufactured together with CSL, Takeda, and many others. And some of the data that you will see is based on the hyperimmune, that material that we manufactured as part of the alliance. And then there's, of course, also the immunoglobulin that we've been manufacturing throughout. And no, we didn't start manufacturing this in January 21, as this slide seems to imply. This is just to show that the data that you will first see is the one derived from the hyperimmune material, and the data that you will see on my slides later is derived from the Pathogen that we have manufactured during these time periods. And that, the biggest difference is that the hyperimmune was from convalescent plasma versus Pathogen that we've studied is in that period where vaccinations already were rolled out too. What it doesn't cover yet, and that's important as well, is the time period of Omicron. So all the data that you will be seeing on my subsequent slides are from product made from plasma before Omicron came around. And here, coming to the data of the hyperimmune batches, both plasma and product. And I would just like to talk to you about the difference in composition and their contributions to potency. Convalescent plasma is different to the final product. In the case of convalescent plasma, what you find is the potency is found to be sitting with both the IgG and the IgM fractions of the plasma. IgM carries quite the punch, actually. However, that really isn't relevant to our immunoglobulin preparations, our IVIGs, because they're highly purified IgG precisely. There is a minimal amount of IgM. So what we looked at next is what is the contribution of the IgG subclasses to the potency. And that one was quite interesting because IgG3 is really one of those that makes up the smallest part of total IgG, but it carries a significant amount of the potency, which is really interesting. And that is something to bear in mind going forward. The other thing that is hopefully obvious to everybody by this point is vaccination really substantially increases the IgG levels against SARS in plasma, and obviously in product by consequence. What you see here is work that had been done and published that we have also leveraged for some of our subsequent work. And you see that convalescents, yes, the convalescents are yellow in comparison to blue, which are native, non-vaccinated people. Convalescents do, obviously, produce antibodies against SARS-CoV-2. However, vaccination substantially increases the titers that are seen in plasma. And convalescents who have also been vaccinated reach slightly different titers still, but the most important thing here to retain is vaccination is what gets you the highest titers. Now this one is probably the one that you're going to look at and go, oh, these are Privigen batches that were manufactured with plasma collected before the occurrence of Omicron. And we've tested these in collaboration with the Kirby Institute in Australia for their neutralization potency against a whole range of different SARS-CoV-2 variants that you see here in the different colors. And the one that stands out is Omicron. The neutralization potency against Omicron is significantly reduced compared to the others. It's not that surprising. We all know by now that Omicron is somewhat different to the previous strains in many of its aspects. And we also know that Omicron is capable of evading vaccine efficacy up to a certain point. So this is an analogous effect. And we are, of course, very interested to know what this looks like with product that is manufactured from plasma that was collected after Omicron was around, that we expect to have antibodies that would have been raised against Omicron. We don't know what this looks like yet. Those studies are ongoing, and we intend to publish these as soon as we can. And here is a statistical model that we built in order to project what titers are going to look like in the future. And this was done in the fall of 2021. And I won't bore you with the mathematics, and in part because I couldn't explain them if I wanted to. But the model inputs are, at the time of the study being designed, were the vaccination and the incidence rates at that time. An assumption of half-life based on the data that was published at that time as well, half-life of the IgG. And changes in IgG as a consequence of natural infection versus vaccination, which is the data that you had seen before. What the model didn't cover is the fact that there was wave after wave of COVID afterwards. It also didn't take into consideration impact of boosters and variants. So bear that in mind when you see the next slide. And it was also based on US data, because that's where the majority of the plasma comes from, as we've all heard. This model, the statistical model, predicted the titers to go much, much higher than what we had initially observed with the hyperimmune that we manufactured early on in the pandemic. And it predicted to peak around December of last year, but to be elevated, even though it doesn't look all that impressive, but to remain elevated at significant levels after that. What we've seen in reality are the blue bars. And you see again, still as a reference line, the titer of the hyperimmune, because the scale has changed here. The line that goes straight up, the black line, that was what our model predicted. And you can see here that our IVIG batches initially followed the model. So the titers increased that we observed in Privigen, but then they did not reach the height of what we had predicted with the statistical model. The good news, however, is that they remained stable at that level that we reached initially. So there was not that drop that we had predicted with the model at all, even though we are at a lower level than what the mathematics had predicted. The reason why the data in real life doesn't match the mathematical model, there are several hypotheses. One, certainly, that we believe is a very, very important factor is the half-life that we based our model on. We have since seen indications that the half-life of IgG is shorter than what was previously published. And this, obviously, with half-life being exponential, has a significant impact on titers, so they wouldn't have gone quite so high up. There is also the question of the variance, what the variance will have done to this model. We've had additional wave, we've had additional variance, and I do think that has a relationship to the fact that the titer remained very constant, but also that it may not have gone as high as predicted, even though the half-life has mathematically a much bigger impact, and we believe that that's really the factor that matters. But the most important thing, again, to retain here is the levels are steady, and that's really, really good news. So in conclusion, the safety is assured. We all know that, and we're very, very happy of that. In the product itself, IgG3 is one of the major contributors to the neutralization potency, even though it is present in the plasma only to approximately 4% of total IgG. And vaccination is what drives titers. The Omicron variant is neutralized to a lesser degree than the previous variants, but again, bear in mind that the plasma on which this data is based was collected before the emergence of Omicron. And the titers of anti-SARS IgG remain stable. Now, I suspect you expected some more specific answers. I would have liked to have more specific answers, especially to the point that Dominica raised before, but it really is a pandemic that's changing before our eyes. There are so many moving parts, and we need to continue to keep learning and to share that knowledge and to draw the conclusions as they come along. And I would just like to point out the many collaborations that we've had: Thermo Fisher, Siemens, Kirby Institute, Sydney University, obviously the Plasma Alliance, which was really a brilliant example of how we as an industry pulled together, and then all my colleagues from CSL Plasma, from Bioanalytics, our pathogen safety team, our digital core, which is our statisticians, our CSL Plasma network, and several colleagues that are listed here that I'd like to point out. Thank you.
Thank you very much, Dr. Widmer, for an extremely comprehensive overview where we stand with regard to SARS-CoV virus and our products at the moment. With this, I would like to invite the next speaker, Dr. David McIntosh. Actually, I've asked for a brief CV. I've received not such a brief CV because he is a man of many trades. Actually, to start with, he's a blood donor, and he has a career, or he had a career in the Scottish National Blood Transfusion Service. He was a general manager there. But actually, since 2019, one of his many jobs, but perhaps the most important one in this context, he is the founder and the chairman of UK Plasma Action, which advocates for the use of UK plasma for manufacturing of PDMPs. Beyond this, he has set up spin-out companies with regard to AI technology. He sits on several boards of other companies. I think, he's also been involved in television, in other services. So, as I said, a man of many trades, and we are especially delighted to talk to him today about where his advocacy stands with regard to UK plasma. We've heard yesterday from the NHS BT England how they're collecting plasma. So, from his advocacy standpoint, Mr. McIntosh, please go ahead. Let us know your thoughts about the use of UK plasma for manufacturing and safety.
Thank you very much, Dominica. Well, what does one say after an introduction like that, except that I do admit to being a jack of all trades and a master of none. After the impressive scientific presentations that we've had throughout the conference, I should start by telling you this is not a scientific presentation. This is a little story about social action and the ability of social pressure from very small beginnings to make fairly significant changes in a country's approach to some of these issues. I am a former head of the Scottish National Blood Transfusion Service. I was the first general manager it ever had. Up to that, it had been successively a charity and then a very kind of informal collection of consensus groups. And it was my task in the 90s to kind of reorganize it and turn it into something which was more akin to a business-like organization. But I'm not really talking from that point of view. My main reason for talking to you is because I've been invited to talk on behalf of UK Plasma Action, which is an entirely not-for-profit organization. It's not just a not-for-profit organization, it's a zero-cash organization. None of us get paid anything for doing anything. But it is a group that we're proud of, and we think we've got a little story to tell. I should mention for complete clarity, I am an advisor to a professional pharmaceutical company, Accord Healthcare, which is part of the Intas group from India, who have a marvelous range of products that are going to patients in the East. But because there are no licensed products in Europe, I can't actually talk to you about Accord Plasma. But if you're interested, look it up. The Intas website has the details, and they do a lot of good work. But I'm not speaking on their behalf. I'm speaking on behalf of UKPA. Now, what exactly is UKPA? Well, UKPA is a loosely knit confederation of like-minded organizations centered on UKPA itself, but with important associate organizations, the Immunology and Allergy Nurses Group, the UK Primary Immunodeficiency Network, which is a network of professional immunologists who are particularly specialized in primary immune deficiency, the British Society for Immunology, and then the two main patient groups in the immunodeficiency field. And it's a sadness to me that we didn't catch on earlier to the fact that we don't have the ITP Patient Association with us, but we're now talking to them to get them on board. And we're still working hard to get the neurology community to pay any attention at all. They tend to plow their own furrow. So, I mean, the title was not mine, by the way. The Curious Case of UK Plasma was given to me. It sounds like the title of some sort of Agatha Christie detective story. I call it the very curious case of UK plasma because when you boil it right down, and as I say, I'm not a scientist, but it's quite clear to me from extensive discussions with scientists that it is a very curious story. So you're all familiar with mad cow disease, which created this zoonotic disease known originally as new variant CJD, now simply called variant CJD or vCJD. The main thing about that was it was an unknown, and it was terrifying. It was consistently absolutely fatal, and it wasn't just death, it was a very, very difficult and harrowing death for everybody concerned, the patient themselves and all around them. So I emphasize that because that is the background to this particular issue. Thomas has talked about viruses, and you know, it's marvelous if you can get a lipid envelope virus, you know you're on a winner. But this prion stuff, there will be half of you here who call them prions and the other half prions. I should say I'm neutral on the subject, please use your own expression. But my good friend Richard Knight, Professor Richard Knight at the CJD surveillance unit in Edinburgh calls them prions, so you know, I share that with you just for interest. So from 84 to 98, and I think this is the core of the issue, many tons of recovered plasma, which allegedly may or may not have had vCJD in them, some of them definitely did with hindsight, were processed into multiple component therapies, including a full range of PDMPs. Now, on my slide, and you'll all be getting copies of the slide, so forgive me if I rush through some of this, with no confirmed cases of transmission of vCJD in any plasma product. Now, there'll be those here who are familiar with Pedden et al. I've got all the references. Please read up on it. I stick to my statement. There is no confirmed case of any transmission of vCJD, whatever, via any plasma-derived medicinal product. Nevertheless, from 98 to 2021, which was when UKPA started sort of muttering and mumbling and eventually screaming, red cells, platelets, FFP, etc. from UK donors, was administered happily to patients, with a small exception of some pediatric plasma products which were restricted in the age and the likely risk of vCJD in the donors. But the vast majority of that fresh frozen plasma, platelets and red cells, went into patients during that period. And during that period, 65 million units 65 million units of fresh components went into patients without a single issue in relation to vCJD at any point. I say that slowly because it is quite important. I don't suppose any of you are familiar with any product, pharmaceutical, blood product or otherwise, that had a clinical trial involving 65 million cases. That's a pretty good application for a license, don't you think? So there it was. But that plasma was not allowed for PDMP production because, of course, they had never listened yet to Thomas Creel and his tripod. They didn't realize that processed plasma was vastly safer than unprocessed plasma, so they just went on giving unprocessed plasma to unsuspecting patients and kept their fingers crossed. The ban was eventually lifted in 2021, and we'll come on to that, but still only for one PDMP. So why? Well, of course, and it really is important to take this seriously. You know, there are aspects of this curious case of UK plasma which makes everybody involved look slightly mad. It looks very stupid in hindsight, but at the time it was absolutely terrifying. And the predictions of possible infection, possible incidents, possible long incubation periods was such that really nobody was in a mood to take any risks at all. And therefore, the potential danger loomed large in everybody's minds. And there were those three cases, four arguably, you will know this if you know the references, where there was transmission of vCJD by red cells, and those patients, of course, like all patients with vCJD, died a very unhappy death. And therefore, we knew that red cells were dangerous, so we banned the plasma. And I leave you with that thought, but I only say to you that that was because there was no alternative. Nobody gets their red cells from anywhere else, but there was an alternative supply of plasma products. And at a pragmatic level, however funny it may look in hindsight, one can understand why it might have been. Deep uncertainty and fear. However, it was intended as a temporary measure, and it's in the written documents, and you can look them up in the references. You know, it was an interim precautionary measure. And they had hoped, quite specifically, they said, we will return, of course, to using plasma just as soon as ever possible. But the various bodies that were associated with that and whose task it was to invigilate this gradually disappeared, mainly because vCJD was so vanishingly rare that it wasn't worth spending any time and money on it. A test was designed and built and reasonably well tested. But of course, it was impossible to put it into practice because you couldn't get enough patients to do any proper trials of it to find out whether it was effective or specific. And therefore, vCJD became something of the past, and everybody just forgot British plasma. You know, I had spent every working hour worrying about British plasma. We were self-sufficient in Scotland. Absolutely every single drop of every component we could think of, including fibrin glue and alpha-1 antitrypsin and you name it, was being produced. We were fully fractionating. We were totally self-sufficient. And I woke up every morning hoping there was going to be enough factor VIII in that plasma to serve the haemophilia community. Now things had moved on, and we can't go into the detail of that. But the point is that the British health system had forgotten about plasma. It had institutionally just kind of passed on. So why? Well, I promised you this was not a scientific talk, and the established evidence is not the subject of what I'm trying to say. Happily, I believe a new scientific consensus has emerged, and I don't think there's any mileage in going over the ground and wondering whether one positive spleen sample in 23 was a reasonable deduction of infection when the guy had no symptoms and died of something else. There's a lot of stuff you could talk about. And I have got some references here which will be in the printed versions and the online versions of my slides if you would like to look at them. What I'm trying to do today is just outline the story. How did it happen? What did we do? And maybe possibly some lessons for the future. Now, I'm going to dash through the references. These are for later reading, but I dash through them with a slight over-commentary. If you read the latest EMA guideline, the draft, is any of you old enough to remember, it was issued in October 2018, and they were going to report some time ago, but they haven't yet. If you look at the references in that, and you look at the dates of the references, and you look at the references in the similar, almost identical document issued in 2007, you'll find they're rather similar. And for those of you who are in the academic world, I think you'd agree if you study that paper carefully, you would not have accepted it from a student. You would have told them to go home and read it again and write it again. So it was not a happy situation, and we as blood donors and as people concerned with plasma and as people aware of the shortage of plasma in the world, which became clearer and clearer as one talked to clinicians and to patients, one was looking for a sea change in the approach. Now, happily, it seems to me that has happened. I mean, France has remained stalwart on this. They had vCJD, but they absolutely didn't ban their own plasma. Thank you very much. And they didn't regret it. We in Britain did ban our plasma, and I don't suppose they've regretted it, but I certainly personally share some regret with you today that £1 billion worth of British plasma has been thrown away, arguably completely unnecessarily. So it was a bit of a sadness. However, in 2018, the EMA started a review, and that's the long reference to it, which is in the list of references. And for those of you who have read it, as I say, it's not very proud of itself. In 2019, the Irish Blood Transfusion Service revised their position. The new MHRA position was announced in 2021, February last year. Now, I do commend to you the Australian decision. If you read the Australian paper, they dropped their deferral rules, but that's not the point. The point is they did a very careful, very professional job on a risk assessment. I mean, for those of you who don't know, the MHRA has not done a risk assessment. They have not updated the risk assessments they were using 15 or 20 years ago. What they did was the risk management. And they said, well, the risk of vCJD is pretty dreadful, but we're a bit short of IG, so it's worth the risk. Now, that's the way risk management works, I'm told, but I have to confess to this audience that's partly our fault at UKPA, because what we said to the MHRA was, A, look, British plasma is safe, reference, 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 reference. But just because it's safe, it doesn't mean you have to use it. But please do use it, because IG is short. Well, they read the second paragraph, but not the first. So you've all seen the headlines in the Pharmaceutical Journal here in Europe. British plasma safe enough for IG. Well, if you're an ITP patient or a primary immune deficiency patient, are you happy that it's safe enough? It's not safe enough for albumin. Don't go selling any of that stuff to China. It'll kill them all. You know, I mean, it's a wee bit odd, isn't it? It's a little bit odd. However, there we go. But the Australian position, if you look at the numbers, please look at the numbers in the Australian reassessment of the risk, because they are many, many orders of magnitude greater than the MHRA's figures. Now, that's not the MHRA's fault, by the way. They inherited that risk assessment. They didn't feel they had time and bandwidth to do it, so they threw themselves at the key priority issue of the moment. They looked at the IG situation. But Australia has, obviously, because they weren't concerned, that's the thing to note. Australia wasn't concerned with plasma for fractionation. They're concerned with fresh products. But in their report, you'll see that they say, look, we didn't deal with plasma for fractionation. It's in writing in their paper, because we know that that's much, much safer anyway. There's no point in talking about it. But we were worried about red cells, and for the following 973 reasons, we think they're safe too. But if you're looking for good arguments in this context, the Australians have done a very, very good job, in my view. The FDA have announced a similar position. I was hoping that by the time we met today in June 2022, I'd have more to say about the MHRA's position. They are slowly working through their view of albumin to see whether that's as safe as IG or perhaps a little less, or whether they'll take another year to think about it. But there is, as yet, no news from the MHRA on this, though I am told they are committed. I think it's fair to say they have committed themselves to doing it before the end of this financial year. So that's news, I suppose, of a sort. So as I say, I'm going to give you a quick run through the UKPA story. thoughts on the lessons learned and possible next steps. UKPA began as a kind of desk research consultation fact-finding mission. I was asked by the British Infected Blood Inquiry to be a witness, and I had to answer 187 written questions, because as a former general manager of the SNBTS at a time when HCV and HIV and so on were very serious issues, I had to be a witness. But when I was asked to be a witness, I was working and had been working for 20 years in sort of broadcast electronics and artificial intelligence. And apart from being a blood donor, I hadn't thought about blood transfusion for 20 years or so. So I did some research, and I discovered that we were throwing British plasma away. And I said to myself, well, why are we throwing British plasma away? There must be a good reason, said I, as a trusting citizen of a well-known health system. And I spent the first 6 months trying to find that good reason. And it's not that I failed to find it. I spoke to all the experts in the field, including those eminent experts who had in fact been very influential in causing the ban in the first place. And everybody said to me, oh, David, yes, of course it's unnecessary now, water under the bridge, British plasma is the safest houses, but you will never get them to change their minds. Because once you have a precaution, it's a ratchet. It's what I call a lobster pot. It's easy to get into, but once you're in, there's absolutely no way out. However, we formed UKPA in June 2019, a group of mad folk like me who really thought they might actually be able to, knock the tree down with 3 ants and a small hacksaw. And it took a long time. It took a long time before the authorities began to even listen. This is a problem. I call it the moment of inertia of the status quo. Galileo had this problem with the Earth not being the center of the universe. Do you remember? And they were going to sort of hang, draw, and quarter him if he didn't recant. And I got a lot of that. I mean, for those of you in this room who, as I do, believe in and love science, bear in mind the dangers of the consensus. The consensus can be a terrible tyrant. If you don't agree with everybody else, you're probably wrong. No. All the really great inventions and discoveries came as a surprise and had to be argued for against the consensus. So look out for the non-consensual new thing. That would be my key message. However, having got to the point where people were listening, and I thank the EMA for this, because they had issued that paper and it was a consultative paper. And I said to the British authorities, presumably this being mainly about British plasma, you will have something to say, because I could see defects and I thought it was worth commenting. And no, they said no, we were co-authors of this, so we're not going to comment. Well, there I am, okay, advocating for British plasma, and the British authorities don't want to advocate for their own plasma. Now, it was clear that what was required was a very, very careful analysis of that EMA CHMP paper. And for those of you who haven't seen our response to it, it's on their website. Please do have a look. I mean, we basically went through it line by line and just said, well, politely, no, you've got this wrong. You haven't thought about this. You've missed out that. And so, thank goodness, before the deadline in October 2019, we did get an official document in, which was from an official UK body backed up by professional organizations, which left the EMA in no doubt that there were at least some in the UK who thought it was high time they had a serious revision of UK plasma safety. And I think that has turned out to be pivotal. They agreed to consider it just before COVID. And though COVID was just the most harrowing experience, and I've lost friends to it, it did have one good benefit, and that was it stimulated the UK into thinking much more about plasma. And I would like to pay tribute to NHSBT, who in the very most amazingly short time threw together a network of convalescent plasmapheresis centers across the UK, over 40 such centers. And that would never have happened if it hadn't been for COVID. And our original UKPA campaign was about recovered plasma. As blood donors, we don't like half of it being thrown away. But because of COVID, our ambitions were elevated, because suddenly we had a pheresis capability. And that capability, nurtured by Jerry Gogarty, who you've listened to already at this conference, is ready and willing to start really making a go of this. We need something of the order of 2 million litres a year of plasma to meet the UK immunoglobulin requirement. And personally, that would be my goal, though I'm 75 years old already, so I may never see it in my lifetime. But that would be my goal, to get there. And the UK government...
Sorry, David, just be mindful of the time. I'm sorry to interrupt you.
I'm 11 of 15, it says.
Okay.
Is that right? No,
Yes.
I mean, is it 15 or is it only
just,
12?
No, it's just that I'm trying not to delay too
Right.
much my
I
colleague.
will rush
Maarten,
on.
will you give us a little bit more time so David can finish? Thank you very much.
Okay, I'm
Please go
just
ahead.
following this. It says Folly 11, Fon 15, so I'm doing...
Please go ahead. Just.
Okay, now just make the point that, I mean, this is all a very simple story to tell, but there are 8,062 emails on this subject in my system at the last count. And there are two words I think that I would commend to you here. One is persistence, and the other is patience. You really can't get overexcited with this stuff. It just takes forever, but it can be done. So lessons learnt. I mean, I don't blame anybody for this. I think it was one of those things, and the lessons are about watching out for structural deficiencies which just leave you uncovered. The night watchman had been sent home. You know, nobody was looking out for the hopeful possibility that vCJD was no longer a risk. They were just looking out for new risks. And every time you get a risk, you put it in the lobster pot. So, I mean, that, I think, is the key message. It was a national strategic failure, and there was a lack of high-level oversight. This was not something for the detailed people in the MHRA. This was for Department of Health oversight. And there was I believe there was an insufficient systematic application of science. But I've got this from Turacek, Hibbert, and Creel, two of whom are here. These are their words, and I think it sums up the situation very well. They were talking about the general situation. I would say it applies equally to the UK. There is an urgent need to update laws and regulations, and there is an urgent need to keep laws and regulations under constant review. Positive engagement, and I think we've heard a lot about engagement and collaboration here, which is enormously helpful and encouraging. And the appliance of science. These are their words, not mine, but I absolutely endorse them. Future engagement has to include more transparency. We're a little bit too secretive in the regulatory field. Not enough peer review, not enough openness. If there were more, we would avoid silly mistakes like this one, and it did last 20 years. Focus on patients, not politics. Since we're in Berlin, I thought we should just pay respects to Hegel. He's usually right. He is usually right. However, maybe this time he won't be. Thank you very much for listening.
Thank you very much, David. And I am mindful of the time, so I would like to open the session for questions. Please come quickly. So, no pressure. Questions, comments? I have plenty. Brian.
Very entertaining, David, really. I enjoyed that. I think going back to the decision to ban UK plasma, a lot of it was based on the DNV risk assessment, which was basically an extrapolation based on assumptions and mathematical modelling. And I know at the time I spoke to a couple of the authors of that, and I got different viewpoints from them about why some of the numbers were there. So I think it was a very difficult situation. I think it was also affected by the history, the appalling history of the transmission of HIV, hepatitis B, hepatitis C through blood products. Variant CJD looked very, very scary. The implications for recipients of blood products, if it had been easily transmissible, would have been appalling. So I think the ban was justified, but maybe not for as long. Maybe it should have been reviewed on a more regular basis.
I would agree entirely with that, Dominica. Absolutely. It should have been reviewed on a much more consistent basis. There's a thing about risk management, if I may just expand on this a little bit. In risk management, you look at the severity of the thing were it to happen. You know, like something absolutely appalling, like the HIV. And I mean, I lost friends to HIV and haemophiliacs, and worked very closely with the Haemophilia Society in those days. The possibility was horrendous, and that causes genuine and understandable fear. But then there's a quite different thing, which has to be handled with a very cold-blooded scientific approach, and that is the likelihood. Now, if they had genuinely believed that plasma was perilous, What on earth were they doing putting it into fresh plasma into patients? What were they doing putting red cells into people? The fact is that you cannot believe that they really thought it was that dangerous. You just can't believe that they did. However, I absolutely accept, and I did say in my talk, that for a period of time, sheer baffled shock, it was worth doing something, and that precaution was probably wise for 1, 2, 3, 4 years. I talk about the red cells as being the canary in the mine. I mean, once you'd issued 1 million red cells and nothing had happened, and you knew from the literature that red cells were more dangerous than plasma, why wouldn't you review it? And I reckon maybe if they'd reviewed it after 2 or 3 years, that would have been fine. But 23 was a bit much.
Thank you. Any other questions from the audience? Well, then I can start with mine. So perhaps a question to Eleonora, because this is incredibly important for the patient community. So can we actually do we know whether the antibodies, the anti-SARS-CoV antibodies that we have in our immunoglobulin preps, whether they can actually afford any protection to patients who rely on these products? Can we make any assumptions at the moment?
We don't know a titer that is protective. That far we can't go, but we have a lot of indications from animal studies, from cell-based assays that show neutralization for the various subtypes, especially with plasma or product that was derived at the time that it had already been circulating the variant of interest. And I think there's more data coming shortly. I mentioned the work that we're doing. Thomas mentioned some work earlier to me that he's doing that has the potential to give us more concrete answers. And I would have wished, honestly, that we could have gotten this answer already from all the many convalescent plasma studies that have been done in a non-randomized and randomized manner. I think that we're all aware that in the beginning, there was just not enough information out there. It was compassionate use and so on. There also wasn't that common reference material that could tie the data together to make it more easily comparable. And now we're at a stage where we have many of these things in place that we can really start working and start drawing these conclusions. But no, the short answer is no, I can't give you a titer.
Thomas, would you like to complement that? Because we have discussed this previously. So do we have any studies on actually patients who were treated with IG lots collected during the pandemic?
So that is something that we hope to reveal shortly. We're still testing all the lots for not only utilization of Wuhan, but also Omicron now, and that normalized to the international unit so that it can actually be comparable. And the hopes is that we would see the incidence in patient populations early treated without antibodies in their IG being higher and now being lower with a more potent product coming in. And with that inverse correlation, we hope to derive what the protective antibody level is. But it's work in progress. It's not ready yet, but something we're taking a look at, yes.
Thank you very much. A question to Dr. Offergeld. I mean, your talk was a little bit too split, very scientific and then very conceptual. I would like to go to the more conceptual part on the supply issue. Obviously, we have all heard that immunoglobulins are on the forefront of supply concerns that we all have. Are there any plans to address it? I mean, you said that you are addressing it currently with the Arbeitskreisblut. Is there any plans to we are from some countries we are hearing supply demand management programs. Is this a way forward that for instance the Arbeitskreisblut would consider? Is this the way forward?
I wish I knew the precise way to go forward about this, but we do actually have also a subgroup that's dealing with demand management plans for plasma derivatives as well, especially IgG, and we included a lot of clinicians in our group to see what can be useful and what not. do we need demand management plans in peaceful times where there's enough product available, enough IgG on the market and ready for the use of patients, or do we need it in case of shortages? And how do we monitor shortages? Is there enough information from the companies, from regulatory bodies to see when a demand management plan would actually going to come into effect? That's something that we also address in one of our groups, and which will eventually then go into our large comprehensive paper that we are hoping to reach within the next months.
Thank you very much. And perhaps because it has been mentioned, has been quite prominent in the news, and this is to all the virologists, scientists here, monkeypox, that we need to worry from the perspective of plasma product safety.
Well, if I may, so
yes, please.
with respect to plasma product safety, I do not believe we need to worry. There is robust inactivation removal capacity for this particularly large and sensitive virus. We've actually done work some 15 years back that even sterile filtration takes the virus out. So from that perspective, I don't think we have a concern. We had that conversation Monday evening. In the blood world, we don't quite know yet. Overnight, actually, the first 2 German cases were reported, and they did find some traces of DNA, not infectivity, DNA in blood. So we'll have to keep monitoring what is out there. What is clearly going to come is, with now 3,000 cases at the desk of the World Health Organization, this is a concern. Whether they're going to elevate it to a public health concern of international dimension, just to be able to better safeguard against transmission chains and what have you, I think it will have to await a little further. But it's quite possible that we're right now still looking at the tip of the iceberg, because clearly the virus has been in circulation for much longer than it was appreciated. So we don't believe concerns go away by doing this. We do this. We're going to focus very clearly on the evidence and then hope to make sense.
Thank you. And one last question. I promise, Maarten. David, perhaps because I asked the same question yesterday to Mr. Gary Gogarty from the NHSPT. Your thoughts on the ECDC risk assessment on UK plasma?
Well, it was interesting because there was a dreadful sense of deja vu when I read that, because just a short anecdote. I mean, the situation with this kind of thing very often is you approach authorities and they go to the file. And some very capable person writes you a very realistic note explaining to you why the up-to-date situation is as follows. And you happen to know that actually it was written in 1990-something. The ECDC simply took the position as they understood it historically from the EMA's previous position, from the MHRA's previous position, and they did what would have been thoroughly logical if all of that background had still been the case. But they weren't up to date, so bless them again. If they had been students, you would have sent them back to the library. They just got it wrong. But I mean, well, it doesn't blame them for that. People do make mistakes. But that was a pretty big mistake because it really screwed things up for the industry. And I regret it deeply, but you know, these things happen.
Thank you. I guess then with this, I would like to close this session. I would like to very much thank my speakers who have taken the time to sit with me. Thank you very much for this very informative session. And with this, I would like to hand over to Maarten, who will close the IPPC. Thank you.
Thank you. Thank you.
Thank you, Dominica. Yesterday, I had the opportunity to inform you all about our new global chairperson. And since he's here at the moment, I would like to give him the opportunity to maybe introduce himself briefly. So, Giles, if you have a moment to do a quick introduction to everybody here.
Thank you, Maarten, and thank you. A big thanks, firstly, to the organizing committee for this conference. I think I speak on behalf of everybody in saying that the agenda has been very robust, a lot of very rich dialogue, not only between industry members, but also external stakeholders, policymakers, patient groups, the medical community. And this is what we need to see at these kind of conferences: good, rich, robust dialogue around the importance of sustainable supply of plasma-derived therapies, the complexity and uniqueness of the PDT business, the costliness of the PDT operations and value chain, and most importantly, the value that these therapies bring to the many patients around the world that depend on them. I thought there was some great case studies shared and some best practice sharing that was very fruitful for all participating. So I'd like to take the opportunity, as I said, to say a big thanks to the organizing group behind this. And I'm very much looking forward to working with you as chair of the PPTA board as a community to ensure that we do deliver on our promise of sustainable supply of innovative plasma-derived medical treatments to the patients around the world that need them. So Maarten, with that, over to you. Thank you.
Thank you. So first, very short, very brief, a couple of formalities before I close the conference. First of all, allow me to thank again as well the sponsors, speakers, the team, the attendees, and everybody who contributed to the conference. As you know, some speakers even did a lot of effort to be here for the past days, like traveling from Ukraine to Berlin. This is not that evident. In addition, we have a passport program, which many of you hopefully have participated to. If you concluded the program, you were able to win an Apple Watch. So the winner is it's 989. I don't know if someone has that number, otherwise we'll draw another one. 870, someone? Congratulations.
Did I understand you correctly?
Yes, that's correct.
Okay, good.
Thank you. Okay. Thanks. I wanted to show you the PPTA mission statement and the 3 pillars under which that we work. And I'd like to show to all of you that during the conference, we've all contributed to those 3 pillars. So the pillars are awareness, plasma availability, and access to PDMPs. Regarding awareness, we brought around 300 people together here in this conference to create awareness around the barriers and the opportunities that exist for plasma and for PDMPs. Key issues were discussed during this conference, like collaboration and partnership. We had a presentation from Gary Gogarty from NHS England, who collaborated with the industry to make sure that everything was in order to start collecting plasma in the UK. We also saw some interesting perspectives on a public-private partnership in Egypt. In addition, Poland and Croatia look very much forward to collaborating with the industry on collecting plasma and building a fractionation plant. We learned this morning as well that authorities should collaborate because testing and collecting of plasma is regulated by one legislation, while once plasma is designated for manufacturing, it becomes a starting material of a medicinal product, which is then regulated by the Pharma legislation. In addition, we heard patients call for collaboration and coexistence to ensure that plasma collection is increased. Also, our members, the industry, are very eager to collect more plasma and to support wherever they can. And a last topic on collaboration, a special thanks to IPPA for the most unhelpful press release on World Blood Donor Day in relation to partnerships. Now on plasma collection, plasma is a unique starting material for PDMPs. So it's really needed to differentiate between policies for blood and blood products for transfusion and policies for plasma for manufacturing. We know that our reliance on the US has increased. It's now 40%, so urgent time that we do something about it. However, I refer back to those partnerships where we can find opportunities. On access, we discussed this morning that PDMPs have a high value for patients and for society. And we learned about the importance of patient access.
rationalizing use to artificially reach self-sufficiency is nonsense. Optimal use is not about restricting patient access, but instead we should all work together to collect more plasma and to leave no patient behind. So with that, I want to conclude and thank you all again for being here, and I look forward to seeing you back next year at IPPC in Lisbon. Thank you.